So good afternoon, everybody, and welcome to this, hopefully the inaugural Barts academic afternoon on insomnia. I hope you'll find the programme we got planned for you today interesting, and we're incredibly fortunate to have some of the leading UK experts on sleep medicine with us here today to share some of their wisdom and accumulated clinical experience. So each of these is going to speak for up to 45 minutes, but don't worry, we've got plenty of time left for questions at the end of each talk. So today's session is intended really to be the first in a series of, I've called it Introduction to Sleep Medicine lectures, specifically aimed at psychiatrists and allied health professionals working across ELFT, looking after people with mental health problems. And this is in part because sleep medicine is given very little airtime in many professional mental health trainings. And that seems pretty surprising given how vulnerable our patients are to things like weight gain-induced obstructive sleep apnea, SSRI or dopamine antagonist-induced RLS or akathisia, circadian rhythm disruption, for example, in schizophrenia and dementia, and non-REM parasomnias and REM behavior disorders. So we would aim to cover some of these diverse topics over a 5-year rotation so that all of our trainees have at least some exposure to sleep medicine by the end of their programme. So I know that all of us recognise the importance of identifying and treating the most common sleep disorder, which is insomnia. They're highly prevalent in those with psychological or psychiatric conditions. But one thing that's particularly important to note is that insomnia isn't always just a secondary consequence of a primary mental illness that will naturally resolve as the underlying mental condition is treated. It may exist independently, it may precipitate episodes of mental ill health, and it may limit the response to both biological and psychological treatments. And because of this, a detailed understanding of the anatomy and physiology of sleep-wake and both pharmacological and non-pharmacological treatment options should be helpful in guiding care. And it's to these ends that today's presentation will be focused. So without further ado, I'm going to hand over to Dr. Dossiter to introduce the first speaker.
Hi, thanks very much for joining everyone. So very pleased to have Dr. Hugh Selsick with us today. I know him from, I do my special interest with him one day a week, which I can highly recommend for SPRs. That's been a really good experience for me. So Dr. Hugh Selsick, he's the lead psychiatrist at the Insomnia and Behavioural Sleep Medicine Clinic at the Royal London Hospital for Integrated Medicine, which is at UCLH, works in the Sleep Disorders Centre at Guy's Hospital. He's chair of the Sleep Special Interest Group at the within the Faculty of Neuropsychiatry at the Royal College, and has a particular interest in the relationship between insomnia and sleep and psychiatric disorders. He recently edited the Sleep Disorders in Psychiatric Patients, a Practical Guide book, which is really excellent and would heartily recommend. So I'll hand over to him now. Thanks, Hugh.
Thank you, and thank you very much for inviting me to speak today. I'm going to be talking about prescribing for insomnia. And I want to start off really with a disclaimer, which is that on this talk, I'm going to be describing some off-label, off-license prescribing practices. You'll be getting a blend of the evidence base, but also some of my own personal clinical experience. And to a large extent, this is because in the UK, the licensed treatment options for insomnia are severely restricted, particularly if you compare the formulary we have for sleep with the United States. It's incredibly restricted. And there are no drugs in the UK that are licensed for the treatment of chronic insomnia. And for most of our patients, by the time they come to us to complain about their insomnia, it has become a chronic condition. And therefore, that means that there is this mismatch between what patients have and what the licenses say. The other issue is that because they have a much bigger formulary in America, and this is where much of the research happens, a lot of the research has been done on drugs that we don't have. And so to some extent, we have to extrapolate a little bit from their data to understand how our medications work. So what is my view of hypnotics? I'm not pro-hypnotics. I'm also not anti-hypnotics. What I am is pro-sleep. For me, the most important thing is to ensure that my patients sleep well and that they feel well in the day. And if I can do that without recourse to medication, that's the gold medal position. If, on the other hand, the only way I can get them to sleep well is with medication, well, that's a silver medal position. And that's not bad. But I think perhaps if I were to ask you to take only one thing away from today, it's this, is that insomnia is a serious condition. We know it's a significant risk factor for depression, for anxiety, for substance misuse. But it's not just a risk factor. It's a serious psychiatric condition in its own right. And it has a similar impact on quality of life to major depression or to congestive heart failure. And we would never leave major depression or congestive heart failure untreated. And so we should never leave insomnia untreated. So what is the purpose of hypnotics? Surprisingly, the purpose is not to improve sleep. The purpose of a hypnotic is to improve daytime function, cognition, energy, and mood. It's to make people feel better during the day. Because insomnia is very much a 24-hour disorder. It's not just what happens at night that troubles the patient. It's much more, in fact, what happens and how they feel during the day with insomnia that really impacts on their lives. So a medication that makes you sleep beautifully at night but makes you then feel awful the next day is the wrong medication. And so the first question that we should ask when we give a patient a sleeping pill and they come back for their review is not how are you sleeping on this medication? The question that we should be asking is, how do you feel on the medication? How does this medication make you feel during the day? And unfortunately, this is actually a question that hasn't been asked in the trials as often as it should be. It's really only recently that people have kind of, if you will excuse the pun, woken up to the concept that question, how do you feel in the day, is the most important question with regard to how well the medication's working. Now, when might you need to prescribe a sleeping pill? Well, if there's acute insomnia, very often it's the only option, because something like cognitive behavior therapy for insomnia, doesn't work fast enough to deal with an acute insomnia. So if someone's got a short-term stressor, they've got a big exam coming up, or there's been a recent bereavement, if they've got kind of sporadic insomnia, only maybe a couple of nights a month where they just sleep really badly and it affects them the next day. If they're traveling or working shifts, then short-term hypnotics can be helpful. And insomnia as a side effect of another treatment. So we know that a lot of our antidepressants, our SSRIs and our SNRIs, for example, when we first start patients on them, they can develop insomnia as a side effect of that medication. That insomnia will often resolve after a couple of weeks, but you don't want them to have a rough couple of weeks, so using a hypnotic to tide them over can be sensible. Now, what about chronic insomnia? Well, you'll hear a lot more about CBT for insomnia later from Colin Espy, and that would always be our first line in chronic insomnia. But unfortunately, in most places, it's currently not available. And for some patients, there might be language issues. It might be that they just choose not to have CBT, that would prefer a medical intervention. There might be a very long wait to get the CBT when it is available, and you don't want your patient to be suffering while they wait for the CBT to start. And as brilliant as CBT for insomnia is, it doesn't work for everybody. And there are some people for whom it doesn't work at all. There are some people for whom it only leads to partial remission of the condition. And so in those patients, they may require longer-term medication. Now, in order to understand how and why we prescribe certain medications for sleep, it's useful just to have a very quick primer on which neurotransmitters are involved in sleep-wake regulation. And the simple answer is all of them. As yet, we've not found a neurotransmitter that doesn't have some role to play in sleep-wake regulation. But the primary ones are these ones here. And there are a number of wakefulness promoting neurotransmitters: histamine, acetylcholine, serotonin, noradrenaline, orexin or hypocretin. They're the same, two names for the same thing. And for some reason I put histamine there twice. I don't know why. And there are two important substances that promote sleep. There's GABA and melatonin. Now, the first thing I really want to point out is if you look at that list, with the exception really perhaps of melatonin and orexin, these are all neurotransmitters that we manipulate with psychiatric medications. And we can also throw in there dopamine. So increasing dopaminergic tone in the brain increases wakefulness. And although we're not sure exactly what role dopamine plays in the unmedicated brain, certainly manipulating dopamine has an effect on sleep and wakefulness. And what that means is that every time we prescribe a psychiatric medication, we have the potential to impact on a patient's sleep, for better or worse. And so it's always important to think, when you put pen to paper to write a prescription, what neurotransmitters am I promoting here? Which ones am I inhibiting? And what could that do to my patient's sleep? And essentially what it means is that if we want to promote sleep, if we want to create a hypnotic effect, then for most of those neurotransmitters that are wakefulness promoting, we need to use an antagonist. So things that are anticholinergic, antiserotonergic, antihistaminergic, and so on. Conversely, for those that promote sleep, we want to use agonists, such as in GABA, we would use benzodiazepines or Z drugs, or melatonin. So let's go through some of these neurotransmitters and the medications that act on them. And the ones that we're going to be most familiar with, the ones that are most widely used, are the benzodiazepines and the Z drugs. These are positive allosteric modulators of at the benzodiazepine receptor and enhance the activity of GABA, which is a sedating neurotransmitter. And the first thing to really address is, do these medications work? Because quite often what you'll read and what you'll hear being said is that, well, they don't really work, that they only increase sleep very modestly, and the reality is that that's not true. When you look at sleep onset latency, total sleep time, wakefulness after sleep onset, and very importantly subjective sleep quality, the benzos and the Z drugs are effective medications. They improve all of these aspects. The zolpidem, interestingly, doesn't increase objective or improve objective wakefulness after sleep onset, because it's a very short-acting medication, but it does improve the subjective wakefulness after sleep onset, and to a large extent, it's the subjective experience that is more important. So the simple answer is these medications work. The next question is, do they work in the long term? And if we are going to be thinking about prescribing these medications in chronic insomnia, that's a really important question. So to answer it, let's look at this study. This was a study by Roth in 2005, and it's a really seminal study using S-zopiclone, which is an enantiomer of zopiclone they use in the States. And to show you what's going on here, this was initially a placebo-controlled double-blinded trial. This is time along the bottom, and people were asked to take the medication every single night. This is the total sleep time on the y-axis in minutes. Now, this is the placebo group, and you can see that there is something of a placebo effect. And this is the active drug, the blue line. Now, what happened is at 6 months, they unblinded the trial. The placebo group then got the active drug as well for the next 6 months. But what I want you to focus on is this blue line. These are the people who have been taking the active drug every single night for a year. And you can see when you look at their total sleep time that there is absolutely no drop-off in the improvement over that year. And in fact, if just eyeballing it, you can see, if anything, there may be even a very slight trend to improvement over that time. And it was based on this study that the time qualifier on Z drugs was removed in the States. So in the States, they can prescribe Z drugs for as long as the patient needs them. There have now been other studies with other Z drugs using different study designs that have again used nightly dosing for a period of a year, and they found the same result, that actually these medications in the majority of patients remain effective in the long term. We don't have trials for quite as long with the benzos. With the benzos, the longest trials that we have for them as hypnotics is only a few months. So if you are thinking about long-term prescribing and you want to prescribe, with the evidence base in mind, you're on safer ground with the Z drugs. Do they work when you stop taking them? And this is a really important point. With very few exceptions, the studies have been almost unanimous that once you stop the medication, the effect of that medication is lost. It only works for as long as you take it. And so this practice that we very often see, particularly in primary care, of giving someone a short course of hypnotics to reset their sleep cycle doesn't work. If they've got acute insomnia, absolutely, it's the right thing to do. But for chronic insomnia, it doesn't work. What happens is the patient goes to their GP, they give them 2 weeks of zopiclone to reset the cycle. They sleep beautifully for those 2 weeks. And at the end of the 2 weeks, the medication runs out. And of course, then the insomnia is no longer being treated, so the symptoms come back. They then go to the doctor and say, please can I have some more of those sleeping pills? And that's when the doctor writes to me and says, please can you see this patient? They're clearly addicted to their sleeping medication, which is absolutely ridiculous. We would never say that patients with hypertension are addicted to their antihypertensives. We wouldn't say that our schizophrenic patients are addicted to their antipsychotics. We would just say they need to use these medications long-term because they have a long-term condition. And if you stop the medicine, of course, that condition is going to come back. So long-term use of a sleeping tablet is not the same as addiction. Now, how do we choose between the various benzos and the Z drugs? Generally speaking, the degree of sedation that these medications provide is very closely related to their plasma level. So we can get a sense of how and when they work by looking at the pharmacokinetics. And here are 4 examples, so zopiclone, zolpidem, and temazepam. And then clonazepam I've put there because it's kind of the steroid of sleep medicine. We use it for almost everything at various times. And if you look at the Tmax, the time to kind of peak plasma levels, you can see that there's not much difference between them. They all kick in pretty quickly, which is exactly what we would want. One medication that doesn't fit into that pattern actually is nitrazepam, which a lot of patients, older patients, are still on. And nitrazepam, the Tmax can be as long as 6 or 7 hours, and that's not ideal because it means they have to take the medication long before bed. Now, where the difference emerges in these medications really is in the half-life. And you can see that there's a big difference in the half-lives of these medications. Zolpidem is quite short-acting. Zopiclone somewhat longer acting. Temazepam, that's a very wide range of half-life, so it's kind of hard to predict. And of course, clonazepam is very long acting. Now, the advantage of a longer acting drug is it does help to keep you asleep through the night, but it then also increases the risk of having hangover the next day. And that's what you have to balance up with your patient. If they're having wakefulness during the night, you may want a longer acting drug, but you have to then be aware that this could cause daytime symptoms. What about melatonin for insomnia? And melatonin is something that we use for the circadian rhythm disorders. We use it for parasomnias, particularly REM sleep behavior disorder, where people act out their dreams. But it is also, and essentially only at the moment, licensed in the UK for insomnia. And it does reduce sleep onset latency, so people fall asleep faster. It improves subjective sleep quality. Because it is short-acting, it's not particularly good for sleep maintenance. It's licensed for over 55s and kids in the UK, but it's sold as a dietary supplement in many other countries. And what that means is that there haven't been as many big long-term trials on safety and efficacy as you would expect for a medication, because it's not classed as a medication in most places. But on the other hand, we are able to collect a lot of real-world data on real people taking the medication for long periods of time, and so we can get a good sense of how safe it is. When it comes to treating insomnia, there's no consensus on an optimal dose, and studies of repeated dosing have used dose ranges from 0.1 milligram to 300 milligrams a night, and without any significant ill effects. But having said that, there's very little benefit going above about 6 to 8 milligrams. The dose response curve flattens out quite significantly above that dose. It also starts to become quite expensive above at that point, and often there's a reluctance to prescribe any more than that in any case. But the big advantage of melatonin is it is remarkably safe. With all of that real-world data, we've seen very few significant adverse events. It may be contraindicated in some autoimmune conditions, although it does seem to be helpful in others. And so certainly my feeling is it's always worth a try as a first line, because it is so much safer and so much better tolerated than any other hypnotic. Increasingly, we're seeing a lot of antihistamines prescribed for sleep, and antihistamines are interesting because they can produce their peak sedation up to 90 minutes after the peak plasma level, which makes them potentially very useful for sleep maintenance, insomnia, or early morning waking. But the problem is that most of the antihistamines that in fact, all of the antihistamines that we have in the UK, your diphenhydramine that people get over the counter, the promethazine that's very often prescribed, these are quite dirty drugs, and in particular, they have significant anticholinergic side effects. And that does have some potential significant long-term problems associated with it. We know that if you increase the anticholinergic burden over the long term, it is a risk factor for dementia. It also makes people feel pretty rotten during the day, dry mouth and constipation and tiredness. And perhaps because it makes them feel rotten, we don't see them getting abused very often. Now, doxepine, which we think of as an antidepressant, as a tricyclic, in very, very low doses, is in fact the purest antihistamine that we know. And so in the States, at doses of 3 to 6 milligrams, it's licensed as a hypnotic. And it seems to be very well tolerated, very effective, with minimal or no daytime hangover. Now, we don't have such a low dose in the UK. The smallest dose we can get is a 25 milligram capsule. And so you can do a little bit of alchemy, getting the patient to open the capsule into 100 mils of water, stirring vigorously, and then drawing out a few mils to get that very low dose. But it's a real hassle. And unfortunately, doxepine, despite being a really old drug, is incredibly expensive. Now, so far I've been talking about the role of hypnotics in insomnia in general. But what about in our patients specifically, in patients with comorbid mental health conditions? Do they work? So looking first of all at hypnotics in depression, we know that benzodiazepine receptor agonists, so benzos and Z drugs, do improve sleep when patients have insomnia and are on antidepressants, and they don't interfere with the antidepressant activity. So this very common practice of giving a couple of weeks of a hypnotic when you start someone on an antidepressant is sensible and helpful. S-sopiclone has in fact been shown to improve not only sleep, but to accelerate the response to fluoxetine. And this improvement in the response to fluoxetine was maintained even after discontinuation of the S-sopiclone. Now, this has not been shown with other Z drugs, so it may be something very specific to S-sopiclone. It has, however, been shown in the benzodiazepines. So S-sopiclone and the benzodiazepines improve sleep, and they accelerate the response to the antidepressant. In bipolar disorder, Ramelteon, which is a melatonin agonist available in the States, was tried in a couple of studies in patients with experiencing mania, and it didn't do very much. And that's not hugely surprising because it is a very mild medication and just may not be strong enough. However, it was shown to halve relapse rates in euthymic bipolar patients who have sleep disturbances. Now, whether that would apply to melatonin is impossible to say, but it's certainly a a possibility. Zolpidem controlled release, which they have in the States, and estoppiclone have both been shown to be safe and effective in patients with bipolar disorder. And perhaps unsurprisingly, bipolar patients on who are euthymic are being managed in longer-term mood stabilizer clinics have lower relapse rates in terms of their mood if they're prescribed hypnotics than if they're prescribed sedating antidepressants, which is still a very common practice. In schizophrenia, there is low-level evidence to suggest that zopiclone may lead to greater improvements in both sleep and negative symptoms than the benzodiazepines do, maybe because zopiclone is much more specific for the sleep subunit of the benzodiazepine receptor. S-zopiclone has been shown to improve sleep and cognitive function relative to placebo in patients with schizophrenia, and this is one of the rare instances where when they stopped the medication, the improvement in sleep continued. So this was the one rare case that I'm aware of where a short course of the hypnotic did lead to longer-term improvements in sleep, but the improvements in cognitive function were lost once they stopped the medication. And there have now been a couple of studies also showing benefit of melatonin in patients with schizophrenia, which is really, I think, a nice outcome because often our patients with schizophrenia are on a lot of quite significant drugs with lots of side effects. So if we can treat their insomnia with something very mild, that's going to be welcomed. Now, of course, we also use a lot of medications that aren't hypnotics for the treatment of insomnia. And very commonly, we'll see antidepressants being prescribed. It's almost unheard of for patients to come to the insomnia clinic without at one point having been put on amitriptyline 10 milligrams by their GP. Unfortunately, there's very little evidence base for this practice. This, it's very commonly done, but there's no evidence that these low doses of amitriptyline are effective. The best evidence we have for using antidepressants in insomnia is for trimipramine, that low-dose doxepin, where it's really an antihistamine, trazodone, and mirtazapine, and to some extent paroxetine, although paroxetine can in some patients disrupt sleep. Certainly in our clinic, trazodone and mirtazapine are very, very commonly used. We find that patients tolerate them well, and they can be incredibly good for sleep maintenance insomnia. But the issue to be aware of with the antidepressants is they do tend to have quite long half-lives, so daytime sedation may be an issue, particularly at the start of treatment. And be aware that the tricyclic antidepressants often also have significant anticholinergic effects. And as a result, they may in fact be more toxic in overdose than the hypnotics are. So, avoiding hypnotics in people because you're worried about suicide risk and giving them a tricyclic for their sleep instead may be counterproductive. Antipsychotics, well, we know that switching from pretty much any typical to any atypical antipsychotic improves sleep parameters, probably because of the antihistamine effects. In primary sort of standalone insomnia, low-dose quetiapine in open-label trials has been shown to improve sleep, and certainly in some countries, GPs will use low-dose quetiapine the way our GPs use amitriptyline as their first line for treating insomnia. Certainly, most of the atypicals, such as clozapine, olanzapine, quetiapine, risperidone, ziprasidone, at antipsychotic or mood stabilizing doses improve sleep in patients with major depression, bipolar depression, and schizophrenia. How much of that is from the sedating effects and how much of it is from the fact that you are treating the comorbid psychiatric condition is difficult to know. However, because a lot of these medications can have quite significant side effects, they're generally not recommended as a first line, other than possibly low-dose quetiapine. The other thing people also, of course, worry about is the risk of falls, particularly in the elderly. And we know that there is evidence that there's an association between hypnotics and falls, but there's also an association between antidepressants and anticonvulsants and falls in the elderly, and a causative association has not been proven at this stage. There's also evidence that insomnia itself increases the risk of falls. If someone is tired all the time, they're not paying attention, they're also more likely to be wandering around at night, their risk of falls, of course, is likely to go up. And that it may in fact be the insomnia rather than the hypnotic that's raising the risk of falls. So when we see an association between hypnotics and falls, it might be the medication that's causing it, but it might be that the medication is just a marker for the insomnia severity. It also seems that giving a hypnotic may be less risky than giving an antidepressant, again, probably because it has a shorter half-life and fewer anticholinergic effects. So some practical advice on prescribing. Before prescribing, there are a few things you want to do. You want to check that they have insomnia. You want to pluck the low-hanging behavioral fruit. Be aware of any comorbid medical and psychiatric disorders. Check what other drugs and substances they are on so that you can make adjustments if need be. Check their social circumstances, occupation and driving status, and be clear on which part of the night they have the problem. When in the night do they have the insomnia? And I'm not going to go through all of these because some of these are fairly obvious, but I just want to focus on a few of them. So first of all, you want to check that they genuinely have insomnia, because not everybody who comes to you and says, "Doctor, I can't sleep," has insomnia. They may have restless legs. They may have a circadian rhythm disorder. They may have obstructive sleep apnea. We often think that everyone with obstructive sleep apnea presents with sleepiness, but actually a significant proportion can present with insomnia. There might be, I don't know why I put sleep there twice. I must have been a bit sleep deprived myself when I wrote this a couple of days ago. So do they have sleep deprivation, which is not the same as insomnia? Sleep deprivation is where you're not getting enough sleep because you're not spending enough time in bed. We don't have the opportunity to sleep. This is the people who are working late and getting up early. And that's not the same as insomnia. Or are they just someone who needs less than the average amount of sleep? Some people only need 5 hours sleep and they feel very well with it. So you need to be sure that you're treating insomnia, because the way you manage these other conditions is very different. Pluck the low-hanging behavioral fruit. So are there any obvious maladaptive behaviors that you can correct? I remember being asked to see a patient he was a schizophrenic gentleman who would spend all day sitting at a coffee shop in Camden Town with his hat and his pipe and drinking coffees. And I asked him how many coffees he drank in a day, and he said it was about 16. And I said, "Do you think that might be why you're having difficulty with sleep?" And he said, no, that's not, because I switched to lattes after 6 p.m. And he wouldn't believe me that lattes have just as much caffeine as espressos do. So are there any obvious behaviors that you can correct? And I'm sure Colin will talk to you about some sort of brief interventions that you can put in place with your patients, behavioral things that you can do in the last talk today. But it is important to stress to your patients that they need, if they're going to get a medication, they do need to engage with a behavioral treatment program as well. And the way that I explain this to patients is I say to them, you need to understand that hypnotics are not anesthetics. They do not make you sleep. They can only help you sleep. That means you have got to take yourself 95% of the way to sleep, and the hypnotic just gets you over the line. And if you don't take yourself 95% of the way, that medication will not work. So you need to do absolutely everything right for your sleep and not just rely on the tablet. And this is when we introduce the importance of the CBT for insomnia. The other reason why this is an important concept to get across to patients is that if they are sleeping well on the tablet, what that probably means is that they are not as bad asleep as they thought. It means they must be taking themselves 95% of the way. And therefore, if they can sleep well with the medication, there's at least a chance that they may be able to sleep well without it, with the right interventions. Alcohol and hypnotics. So combining alcohol and hypnotics is a very high-risk practice, and the vast majority of fatal overdoses with hypnotics have been in the context of alcohol and other sedatives. And I certainly would never prescribe a hypnotic to someone who is actively alcohol dependent. And here I'm talking about the person who starts drinking in the morning and drinks through the day. I will not give that person a hypnotic. I will consider giving a hypnotic to the person who starts drinking at 10 p.m. in order to sleep. So the patient who doesn't drink during the day, but says, I drink a bottle of wine every night because it's the only thing that gets me to sleep. And I would much rather they were taking a Zopiclone every night than a bottle of wine every night. It's going to be safer for their liver and their bone marrow and their brain. But obviously you'd want to monitor them very closely to make sure that they don't drink on top of the hypnotic. You want to know about their driving status and their occupation, because a lot of hypnotics, because they can cause hangover, do impair driving performance the next day, particularly a lot of the benzos. But the one I really want to point out are Zopiclone and the tricyclics. So you'd be very cautious about prescribing these to people who drive in the morning. Zolpidem, the FDA in America have said one should be cautious about giving it if you drive in the morning, but objective studies done in the Netherlands using Zolpidem didn't find any impact on driving the next morning, and melatonin seems to be safe in this regard as well. But even if I'm giving a short-acting medication, I would always warn patients just to be very wary and really be honest with themselves about whether they are safe to drive. And a good rule of thumb is I ask my patients not to drive for at least 13 hours after taking a dose of Zopiclone, or at least 9 hours after taking a dose of Zolpidem. When the mama bear is asleep, she can't keep an eye on the baby bears. And the reason I point this out is because one of the questions we always need to ask is, are you a carer for a child? Are you a single mother caring for somebody? Or do you care for an elderly parent at home where you may be called out at night? And if that's the case, I really would avoid hypnotics, because what you don't want is for a child, who to feel unwell in the night and their parent can't respond to them. On the other hand, if they work in a profession where their insomnia significantly affects safety, then I might be much more aggressive about giving them a medication. I might be very quick to get them onto a medication to ensure that they can carry out their work safely. And then when in the night do they have the problem? Is it at the beginning of the night, the middle of the night, the end of the night, or a combination of these? If they have initial insomnia, just difficulty getting off to sleep, then using a short-acting drug like melatonin or Zolpidem is ideal. It gets them off to sleep and minimizes daytime hangover. If it's insomnia in the middle of the night, then using Zopiclone, which is longer acting, or a sedating antihistamine or antidepressant is better. And this is where I would use something like mirtazapine or trazodone. And for terminal insomnia, and terminal insomnia is a term you should never actually use with the patient because it will freak them out. So we'll call it early morning waking. Use a longer acting drug like Zopiclone potentially, or again, a sedating antihistamine or antidepressant. And in this case, you would take it at bedtime. If they have initial insomnia and mid or terminal insomnia, so they have difficulty getting to sleep and staying asleep, then again, I would use either Zopiclone at bedtime, or I would use a sedating antihistamine or antidepressant. But because these take a while to kick in, they would need to take that an hour or two before bed. So the timing is different. If they also have sleep initiation insomnia, you want to take it earlier than if they've just got mid or terminal insomnia. And this really leads me to an important point. When do you take a hypnotic? I'm amazed, how many patients say, well, if I take the tablet at 11, I fall asleep at 11:30. So if I take it at 10, I will fall asleep at 10:30. And then that doesn't work, so they try taking it at 9, and they end up taking their medication at 6 in the evening and going to bed at 11, which is a very dangerous practice. So Z drugs and benzos, we say to our patients, these are pajama drugs. You should be taking them only as you get into bed or within the first hour of going to bed. If after you're in bed for an hour and you think, okay, this is not happening tonight, I need a tablet, that's fine, but not after that first hour. If you take the drug any earlier, there's a risk of falls, cooking in your sleep, driving in your sleep. And also, it means if you're taking your medication at, say, 6 and only going to bed at 10, by the time you go to bed, the plasma levels already started to drop, and that makes the drug less effective, which means the patient's going to start wanting to take more of the medication. If you take the drug any later than an hour after going to bed, then you have a significant risk of morning hangover, and you also might then get the patient oversleeping the next day, which is then going to have a negative impact on their sleep the following night. So for the Z drugs, benzos, only at bedtime or within the first hour of going to bed. The antidepressants, the sedating antidepressants, you can take at bedtime or an hour or two before bed if you have difficulty getting off to sleep. How often should a hypnotic be taken? Well, some patients, as we've said, will take hypnotics every night for decades with no problems. I saw a patient yesterday who has been on nightly zolpidem for the last 30 years. He sleeps beautifully, has no side effects. He's well into his 80s. But if you are concerned about tolerance, then intermittent dosing may be sensible. And very often what we see is the patients get given 14 tablets a month so that they dose intermittently. And I'm not sure that this is a great practice, actually, because although it might reduce the risk of physiological tolerance, it does increase the risk of psychological dependence. You get a situation like this. I'm only allowed 3 tablets a week, but I've got 4 big days at work next week. So maybe I should just save one of my tablets from this week. But then I've got a wedding on the weekend and I want to be fresh for that, so I may need a pill for then. I wonder if I left any tablets at my mother's. Oh my gosh, I just wish I had more pills. When you give medication intermittently, patients start to plan their entire lives around the medication. They will only plan social things or work things or difficult tasks on days after they've had the medication. They'll avoid things on the days when they haven't. And the medication therefore becomes the central axis of their lives. Whereas actually, if you give it to them every night, it just becomes something they do, and they become less psychologically dependent. And then finally, deprescribing. Obviously, it's important to regularly review the efficacy of the medication, check for side effects or changes in the patient's circumstances. What we know is that you are more likely to be successful at stopping a hypnotic if you do a gradual reduction than if you go cold turkey. And a good rule of thumb is 25% reduction every 1 to 2 weeks at the fastest. Warn patients that they may, when they reduce the dose or stop the medication, get a rebound insomnia, which is a temporary worsening of the insomnia, and stress that it is temporary. Because if they reduce the dose and they have a couple of really awful nights, they're going to say, this is not working, I've got to go back onto the full dose of medication. Whereas if they understand, okay, this is just my body adapting and things are likely to settle down a bit, they can often tolerate it. And then don't remove a medication unless you intend to replace it with something else, preferably CBTI. Because remember, this is a serious illness and should never be left untreated. And I'll stop there and take any questions. And I apologize for the slight gap in the middle when I had to go and tend to my puppy who was eating something that she shouldn't have.
So I've collated a few questions from the chat, so I sort of grouped them a little bit. I think a couple were sort of popped up in the chat, and then I think they got answered. But there's a few questions around sort of Z drugs and benzos, I think. So one question was, should I go through a few and then you can sort of see if you can answer them, and if you forget, come back to me. So one was around Z drugs and benzos. What do they do to the sleep architecture, REM, sleep latency, and sort of daytime alertness, cognitive function? Was one question. One was a question about sort of alprazolam, and why wasn't that in the kind of included as a kind of one of those go-to benzos? And then there's two more of that. One was around short-term use of hypnotics in adolescents when they've got a reversal of sleep-wake cycle as a means of trying to get the cycle brought back into rhythm. And lastly, one was about cognitive function, impact on cognitive function of Z drugs and benzos in the elderly, with or without with dementia, and also in acquired brain injury. So maybe I can stop there for those four and just
Okay, so
See,
yeah, quite a lot to go through there, and so the first thing is, I guess when looking at cognitive function in general, there certainly is evidence that particularly with the longer acting benzos, that you do get a negative impact on cognitive function, certainly while the medication is in the system. There are a number of studies showing an association between long-term benzos and hypnotic use and subsequently developing dementia. It's important to say that, again, this is not a cause, no causation has been shown. And indeed, when in some studies where they've been able to control, for example, for severity of insomnia, for quantity of alcohol consumption rather than just having yes/no questions on alcohol consumption, etc. So where they've been really able to kind of control for a number of confounding variables, very often that association does fall away. So we don't know what the longer term impact on cognition is. We have to be honest with patients and say that this association has been seen, but we don't know for sure what it's telling us. But yes, certainly with the longer acting benzos, you do get a cognitive dulling the next day. And so if that is a concern, then it makes sense to be on a shorter acting medication. The downside with some of the shorter acting medications is that you can kind of often, particularly with the benzos, get more of a rebound anxiety when you come off of them. This is a problem that's sometimes seen, for example, with the short acting drugs and with alprazolam. That's something that we do see as well, and that's one of the reasons why it's not listed there. So, of the benzos, probably the ones that have the best kind of pharmacokinetic profile for sleep are temazepam and oxazepam, because they kind of have a medium duration of action, and so they're reasonably good for getting people to sleep and keeping them asleep. In terms of the sleep architecture, benzos do have a negative, what appears to be a negative impact on sleep architecture, and in particular, you do see a sort of alpha wave intrusion into deep sleep, which is often a sign of poor quality sleep. It does affect the amount of REM sleep, although we're not quite sure if that's necessarily a bad thing. The Z drugs seem to give a very natural looking sleep architecture. So, if you look at a sleep study for someone on a Z drug, it's very difficult to tell that from a natural, normal sleep. In terms of short-term use with adolescents, I mean, to be honest, I don't know. I don't think the studies have been done. But very often with adolescents, what we're seeing when they have this complete reversal of day-night is not insomnia, but a delayed sleep-wake phase disorder. This is a circadian rhythm disorder where the body clock is significantly delayed. It's very common in adolescence. It resolves in most people once they get to adulthood, but can continue into adulthood. And although it probably occurs in less than 1% of the adult population, it constitutes about 10% of the patients who present to an insomnia clinic. So it's always got to be in your differential when you see insomnia, and particularly when you see insomnia in an adolescent.
Great, thanks. That's brilliant. Also, I've got to encourage people, sorry, to put their questions into the Q&A function. So I didn't realise that existed, so apologies for that, rather than in the chat, but I've tried to transpose them across for this. Okay, so another little group of questions was, so I guess a couple on melatonin. One was, why is it not recommended by NICE for patients with dementia? And then relatedly, can we use melatonin long term, i.e. for more than 6 months in patients who have dementia? And maybe I can just chuck in another one there, which is about cannabis, just any sort of awareness of evidence or advice around medical cannabis, also including over-the-counter kind of CBD, in terms of impact on sleep architecture, improving sleep.
So, so to answer the cannabis one, it's too early to say what the impact of cannabis is on sleep. The studies are relatively few, and the problem up until recently has been that it's been difficult to know what a standard dose is. When using cannabis that's been grown, there's going to be a lot of variability in the product that's being used. the indications seem to be that using very low dose cannabis in the short term may be helpful for sleep. That one does seem to develop tolerance to it quite quickly, so it may not be a long-term prospect. It's also CBD. There's no evidence whatsoever that it improves sleep, and in fact, in theory, when you look at the pharmacological profile, it should, if anything, be wakefulness promoting overall. As regards melatonin, so the reason it's not recommended in dementia is simply just because the studies have found, by and large, it doesn't work. There have been some positive studies, but there have also been some negative studies. And I think that's not hugely surprising, because people with dementia and insomnia are going to be as varied as people without dementia and insomnia. And so I think it will work for some people and it won't work for others. One of the factors is, as we get older, we have fewer melatonin receptors, and therefore melatonin may not be as effective. And particularly where where there is dementia, it's possible that the melatonin system is simply not functioning. How does it make you sleep? There are two ways that it makes you sleep. First of all, it does have a direct hypnotic action. So it is sedating in humans, although not in all animals. And the second thing is that it acts as a time signal to the body and to the brain to tell your body and brain it's nighttime and therefore time to sleep. In terms of whether you can use it for longer than 6 months, so look, it's licensed for 6 months. But that doesn't mean you are not allowed to prescribe it for longer than 6 months. It means the drug company is only allowed to promote it as something that you can use for 6 months. But clinically, if you find that your patient is benefiting from it, that the benefits are outweighing any side effects or risks, then absolutely I would support prescribing it longer term. And for our patients with the circadian rhythm disorders, they often need to be on melatonin for many, many years, or for life. So certainly it's very common in clinical practice to go beyond the license.
Okay, ready for another round?
Yeah.
So a bunch of questions. So, okay, I guess there's a couple of questions that came in around specific groups, which I might just bunch together, but I mean, they're separate questions. But so is it around evidence-based pharmacological intervention for patients with sleep problems so questions for patients with diagnoses of learning disabilities, autism spectrum disorders, ADHD, and I guess more broadly, someone else is asking about children and adolescents. So if I can just group those kind of subsets together as...
Okay. So particularly in intellectual disability, it's an area where there's a huge lack of evidence. And partly, I guess this because, there are multiple different syndromes that might, fall under that heading, and therefore it can be difficult to do studies unless you're focusing on a specific syndrome. Certainly clinically, melatonin is very widely used. And it does, again, seem to be generally quite well tolerated and reasonably effective if it's used in the right way. We would always recommend, again, the behavioral interventions first. Is the person having an inconstant rising time? Are they napping in the bus on their way to the day center every day? Those are the things that we would tackle first, but certainly melatonin is something that we would consider. And there are cases where, if that's not working, we would consider using stronger hypnotics. We might start on lower doses. We might be a little bit more cautious with the titration, but certainly there are patients who do very well with straightforward hypnotics. Again, with autistic spectrum disorder and related disorders, there does seem to be a higher rate of circadian rhythm disorders, and this is most marked in ADHD, where around 75% of ADHD patients, both kids and adults, have a significantly delayed body clock. And therefore giving melatonin to advance that body clock, and that's done in a slightly different way from in insomnia, with when you want to advance the patient's body clock, what we do is we give a very low dose of melatonin. Generally, we give 2 milligrams because that's the size of the tablet that we have. But if we can go lower, we will do. And you take that melatonin around 6 hours earlier than the patient fell asleep the previous night. So you're taking a very low dose much earlier in the evening, and that helps to advance the body clock. And certainly we've had great success with ADHD patients using that regime. And then with kids, again, I have to, preface it by saying behavioral interventions are always going to be the first line, and actually, when done correctly, are almost always effective. And perhaps Colin can talk a bit more about what those behavioral interventions would be. Certainly, I know that my wife, who's a community pediatrician, tells me that melatonin is being quite widely used. There is some concern that it might be being overused, but the fact that it is being widely used, I think, is probably an indication, that people are finding it to be useful.
Okay, thanks. We've got a couple minutes, but I think we can squeeze in a couple of quick things. So one was about, and apologies for the question I didn't get to sort of put through. One was about shift workers, night workers, if struggling to sleep, any advice? And one was sort of how reliable are patients' assessments on their own sort of sleep. And then there's one very specific sort of question around this kind of middle of the night insomnia, people wake up and they're worried. It relates to that. Someone was saying we might use search in that case. Is that indicated there? But generally, I'm just lumping those two questions together there, and I think that's probably the last three we can do.
Okay, so with regard to shift work, the best advice I can give is don't do shift work, because the human body is not designed to keep shifting around the clock the way that shift work demands. It is really problematic. Obviously, it's unavoidable for certain professions, and then ensuring that you design rotas in the right way is really important. So, for example, going from if you have someone who goes from a night to a late to an early, they're going to be seriously sleep deprived. Your body can't advance in that way. It copes better with going from an early to a late to a night. I think that there is a role for using hypnotics in night shift workers to help them to get sufficient sleep during the day. But for most shifts, unless you're working on one of these North Sea oil rigs where you might do a month of nights, you cannot shift your body clock fast enough. So there's no point trying to change your circadian rhythm. It really is then about just ensuring that you engage in the best possible sleep habits when you are able to sleep. And certainly there is a role for hypnotics in people who feel they're not getting enough sleep between shifts. Just remind me, sorry, the second question was on.
It was the sort of middle of the night anxiety, sort of wake up middle of the night, then struggling to get back to sleep, and sort of related to that is sertraline as an indicated there as well, or what's the advice?
I mean, I think in general, if someone is not anxious the rest of the day, I don't think it'd really be a role for an SSRI in this case. We quite often are naturally more anxious at night. It's probably what kept our ancestors from getting eaten. And there are some very good psychological and behavioral interventions you can use to manage that middle of the night anxiety. So that would really be the first line. Obviously, if there's lots of anxiety in the day as well, and that's coming up at night, then whatever you need to do to tackle that anxiety during the day is likely to have a beneficial impact on the sleep as well.
Brilliant. Thanks very much. And I think that is time. So there's more questions coming through. They'll see it in the Q&A. There was a bit of love for the puppy. People were wishing to look at the puppy, and a bit of love for the term pajama drugs. Pop
them in the Q&A, and I'll do my best to answer them before I head off.
Brilliant. Thanks very much, Hugh. That's fantastic. I'm now going to introduce Dr. Rex Musa, who's giving the next talk, which is on anatomy and physiology of sleep. Dr. Rex Musa is a consultant in sleep, respiratory and general internal medicine, based at Guy's and Thomas's Hospitals NHS Foundation Trust. He's European Sleep Research Society's sleep somnologist, sleep expert. and works at the Sleep Disorder Centre at Guy's Hospital. He's got a particular interest in sleep disordered breathing, hypersomnia, and parasomnias, and has recently been working with colleagues looking at newer insomnia treatments. He's a respiratory physician and member of the British Thoracic Society. So thanks very much, and over to you, Rex.
Good, thank you very much. I hope you can hear me well. Great. Thank you very much to the organizers for inviting me to talk on this very fascinating topic of sleep neurobiology. This is an evolving topic, and there are lots of newer developments, new information which is coming on every day. Let me see if I can move my slide forward. It seems to be stuck. So it's an insomnia afternoon, and I won't go into the definitions of insomnia. And my colleagues have already mentioned that insomnia is an important condition. But the question is, in the first instance, what is the mechanistic basis for sleep and wakefulness? What are the neurobiological substrates of insomnia? What are the neurochemical mechanisms of insomnia? I'm not going to be talking about insomnia only. I'm going to be talking about the neurobiology of sleep as it affects us in the Sleep Disorder Center. So an understanding of the neurobiology of sleep will help in understanding of how the drugs of insomnia works, will help us in understanding of how drugs to treat hypersomnias work, will help us to understand how various lesions in the brain might manifest clinically. So an important topic to be aware of course, you are probably not going to become too familiar with all the details of the neurocircuitry in the brain, but it is important to have a working knowledge of the neurobiology of sleep. It might be important at this stage to step back into the history because things have evolved over the past 100 years or so. Back in the 19th century, John Hewlings Jackson argued that consciousness was the sum total of the activity of the cerebral cortex, and that loss of consciousness occurred when this activity was prevented. But then, where does the trigger for this consciousness come from? In 1890, Ludwig Mothner reported that patients with Wernicke's encephalopathy developed sleepiness and impaired eye movements, suggesting that this pathology somehow affected the awakening, the arousal system. And then perhaps a turning point came soon after the First World War, when there was this encephalitis lethargica. And Baron van Economo noted that damage to the posterior hypothalamus resulted in excessive daytime sleepiness. And then damage to the anterior hypothalamus resulted in insomnia. So he proposed that an ascending arousal system originating in the upper brainstem kept the forebrain awake in an intact brain. He also posited that a sleep-promoting influence existed that arose from the region of the rostral third ventricle, which would make sense. And then in the 1930s, Bremer showed that if he transected the brainstem of the cat between the inferior and the superior colliculi, so that is between the midbrain and the pons, the animal would fall into an irreversible coma, suggesting that perhaps this area is important for the generation of wakefulness. And later on in the 1940s, Moruzzi and Magoon found that stimulation of the rostral reticular formation cause the EEG of an anesthetized animal to switch from the slow waves you'd see in sleep, in non-REM sleep in particular, to the low voltage desynchronized activity, which is typical of wakefulness. Again, suggesting that this area is important at the generation of wakefulness. And then we know that REM sleep was identified in the 1950s by Kleitman and Azerinsky, and later on, Jove and colleagues established that REM sleep was driven by circuitry in the pons, and those facts are still true today. So we will be looking briefly, not in too much detail, at the anatomic areas which are important for sleep and wake. We will be looking at the neurotransmitters and the neuromodulators involved, at least the ones we know. And like I said, this is an evolving field, and lots of other neurotransmitters and somnogens are being identified. We will be looking at the excitatory and the inhibitory projections of these neurons. We will be looking at the activity of these neurons in the wake state, in non-REM sleep, and in REM sleep. And then to make it more interesting or less boring, we will include some bit of clinical and pharmacological correlates. And Hugh has already given you some clinical correlates which are relevant to insomnia. There will be a bit of repetition of some slides for emphasis. Some of you will be quite familiar with these slides or with these neurotransmitters. Some of us perhaps less familiar. So the neurotransmitters which are important for wakefulness are the noradrenaline, orexin or hypocretin, acetylcholine, histamine, and serotonin. And for sleepiness, you got GABA, ghrelin, adenosine, and prostaglandin D2. But again, there are some other somnogens and neurotransmitters to add to this list. And the diagrams I'll be showing will be using some bit of abbreviations. And these brain areas important for sleep, you need to be familiar with them. We've got the lateral dorsal tegmentum, LDT, which is cholinergic, the pedunculopontine tegmentum, which is again cholinergic, the locus coeruleus, which is noradrenergic, the dorsal raphe nucleus, whose neurons secrete serotonin, the tuberomammillary nucleus, the TMN, which is important for histamine, the ventral lateral preoptic area, an important area, the VLPO, with GABA and ghrelin, and the lateral posterior hypothalamus, another important center for sleep and wake, which has neurons which produce hypocretin 1 and 2, also known as orexin A and orexin B, and then the parabrachial nucleus with glutamate. So again, repeating the same thing, nuclei which are important for wakefulness are the noradrenergic locus coeruleus, the serotonergic dorsal raphe nuclei, the cholinergic nuclei which are in the pedunculopontine tegmentum and the lateral dorsal tegmentum, the glutamatergic parabrachial plexus, the dopaminergic in the ventral tegmental area, histaminergic ones in the TMN, and the hypocretin secreting neurons from the lateral hypothalamus. So we are going to go brain area by brain area, starting by the hypothalamic areas, the brainstem regions, and the basal forebrain. So in the hypothalamic areas, we will look at the lateral hypothalamus, the ventrolateral preoptic nucleus, and the TMN, the tuberomammary nucleus. So starting with the lateral hypothalamus, it's a very important site in the sleep-wake generation, and it is the sole source of the hypocretin secreting neurons. As I'm sure most of you know, deficiency of those neurons, as is found in narcolepsy, leads to hypersomnolence, which is a common clinical problem in patients with narcolepsy. And dog narcolepsy is due to mutation in the gene for the hypocretin receptor. The hypocretin neurons project quite widely. They project to the nuclei in the reticular activating system, the LDT, PPT, the locus coeruleus, the dorsal raphe nucleus. They also project to the dopaminergic region. They project to the TMN, the histaminergic regions, and they also project to the basal forebrain, where they'll stimulate the cholinergic neurons, which then project to the cortex, leading to wakefulness. So wide projections of these excitatory neurons which promote wakefulness. And in particular, they've got a strong excitatory effect on the cholinergic neurons in the basal forebrain, which are important for cortical arousal. It is also important to note that they seem to stabilize the sleep switch. In sleep medicine, we see quite a number of patients with narcolepsy who have deficiency of this hypocretin peptide. And these patients have got very fragmented nighttime sleep, almost like insomnia, with very poor sleep maintenance. Like I said, they project to various structures, to the basal forebrain, to the dopaminergic area, to the histaminergic areas, to the serotonergic areas, but they also have a negative feedback from some of these areas, including the cues of hunger, such as low glucose, the ghrelin, and the leptin. So orexin is important not just for sleepiness, but seems to have other functions, including feeding, temperature regulation, and the like. Clinically, we recognize narcolepsy, and type 1 narcolepsy is characterized by excessive daytime sleepiness, cataplexy, sleep onset and sleep offset hallucinations, and sleep paralysis. So with cataplexy, these patients will lose muscle tone with emotional triggers such as laughter. And a very common clinical condition we encounter in our daily practice in sleep medicine. There's also less severe loss of the hypocretin neurons, which is found in patients with Parkinson's disease, for instance, or traumatic brain injury associated with some degree of sleepiness. It is important to note that the hypocretin system is now being targeted in the development of new drugs which seem to hold much promise. I've been working with the Medscape educational team for the past 2 years, and we've been looking at this DORA, the dual orexin receptor antagonist, and they seem to be quite helpful. They do not have some of the side effects which are associated with the traditional hypnotics, and seem to be effective at sleep initiation, sleep maintenance, and early morning waking. Then moving on to the ventrolateral preoptic nucleus, the VLPO. This area has got the inhibitory GABA and galanin neurons, and they are sleep active. They're active in both non-REM sleep and REM sleep, but silent during wake. They do project to various structures, and they do have an inhibitory influence. So they've got an inhibitory influence on the lateral hypothalamus, where you have got the orexin neurons, inhibitory influence on the TMN, where you do have the histamine neurons, inhibitory influence on the dopaminergic areas, inhibitory neurons onto the locus coeruleus adrenergic one, and the dorsal raphe serotonin. So a very important structure in the promotion of sleep. And these neurons seem to be activated by sleep-inducing factors such as adenosine and prostaglandin 2. Clinically, I think Dr. Selznick has already talked about these drugs, which are really, really important, and they've been used for many years. The benzodiazepines, such as lorazepam, clonazepam, the Z drugs, which are benzodiazepine receptor agonists, such as zopiclone and zolpidem. I won't go into detail of what you have just heard. And then in sleep medicine, we also use sodium oxybate to treat patients with narcolepsy. This is a very potent drug which induces quite deep sleep, sometimes to the point of nocturnal enuresis. And again, it works by binding onto the GABA B receptors. So this area, very important in the generation of sleep. Then we got the tuberous mammary nucleus, the TMN. This is the sole source of histamine in the brain. Again, these neurons project quite widely to the cerebral cortex, to the amygdala, to the substantia nigra, to these sort of brainstem nuclei such as dorsal raphe nuclei, locus coeruleus, and the like. And the histamine acting on the H1 receptors is associated with wakefulness. So their input on most of these nuclei is stimulatory, and it also receives stimulation from the lateral hypothalamic hypocretin neurons. So they do have a high firing rate during wake, which is a bit reduced in non-REM sleep and very much reduced in REM sleep. Interestingly, during cataplexy, where the patients with narcolepsy sort of lose strength in their muscles but maintain consciousness, the TMN neurons seem to be firing quite rapidly, which perhaps explains why they maintain consciousness. We also know that in patients with narcolepsy, there's low CSF hypocretin, and it would appear that histamine is especially important for initiating arousal. And clinically, you will know that drugs which reduce histamine signaling are quite soporific. So these are drugs like diphenhydramine and low-dose doxepin, as we were discussing earlier. And H3 antagonists or reverse agonists, such as pitolisant, promote wakefulness and improve excessive daytime sleepiness, which is commonly seen in patients with narcolepsy. And this is proving to be a very, very useful drug in our armory to treat patients with narcolepsy and idiopathic hypersomnolence. So summarizing the hypothalamic areas, we do have the lateral hypothalamus, which has neurons which secrete hypocretin and has got wide projections in the brain. We do have the VLPO, which has got the GABA and galanin neurotransmitters, which are inhibitory, very important for inducing sleep. Then we do have the TMN, which is histaminergic and also quite important for inducing the wake state. So let's move to the brainstem regions. We do have the dopamine regions, and we do have the reticular formation, an important structure. I think you will remember the dopaminergic regions from your days in the medical school, learning about Parkinson's disease, and will know about the substantia nigra, the ventral tegmental area, and the periaqueductal gray, important structures for the production of dopamine. And dopamine cells, in particular, the ones from the ventral periaqueductal gray, seem to be quite wake active with increased firing during the wake state. But the other dopamine areas do not seem to have such a variable firing rate, whether in the wake or in the sleep. And we also know that dopamine agonists acting on D1, D2, and D3 receptors increase waking and decrease non-REM sleep and REM sleep. So another wake promoting neurotransmitter. And sleepiness is common in patients with dopamine agonists, with dopamine agonists such as haloperidol and chlorpromazine, as you know. And sleepiness is also common where there's dopamine deficiency, like in patients with Parkinson's disease. In sleep medicine, we see quite a few patients with restless leg syndrome, and we use ropinirole to treat them. And it is important to note that ropinirole can produce sleepiness via activation of the autoinhibitory D2 receptors that reduce dopamine signaling. And the dopamine transporter has proved to be one of the turning points in the treatment of excessive daytime sleepiness associated with narcolepsy and idiopathic hypersomnolence. So the traditional stimulants, the amphetamines, they increase wakefulness by increasing dopaminergic signaling, and you will be familiar with drugs like methylphenidate and dexamphetamines, drugs we have been using for the past several decades for the treatment of excessive daytime sleepiness. And modafinil also seems to increase dopamine signaling, another drug which has been very useful in our treatment of narcolepsy for the past 30 years or so. And the new kid on the block is solriamfetol, which inhibits the reuptake of both dopamine and noradrenaline, a very important addition to our armory in the treatment of hypersomnolence. Then the reticular formation, the traditional thinking was that this was a monolithic structure, but we now know that there's some discrete nuclei in that region. We've got the LDT and the PPT. We've got the dorsal raphe nucleus, and we've got the locus ceruleus. So the LDT and the PPT have got cholinergic neurons, and some of these neurons are active during wake and REM sleep only. And these are the wake REM on neurons. And during non-REM sleep, these neurons are inactive. Then we also have the REM on neurons that are active during REM sleep, but not wake or REM sleep or non-REM sleep. And these REM on neurons and the wake and REM on neurons are very important in the regulation of REM sleep. We will perhaps touch on this again briefly in the subsequent slides. Then the dorsal raphe nucleus has got serotonergic neurons, which have a high firing rate during wake and a reduced firing rate in non-REM sleep and minimally active during REM sleep. And the influences of the dorsal raphe neurons is also stimulatory, so another important neurostimulator for wakefulness. And as what Dr. Hugh-Selsik has already mentioned, these 5-HT receptors increase wakefulness and reduce REM sleep. And we see it when we do sleep studies on our polysomnographic studies that they've got significantly reduced amount of REM sleep overnight. And the drugs that bind to the 5-HT receptors, such as agomelatine, promote non-REM sleep, and perhaps might be useful in the treatment of insomnia. Then we've got the noradrenergic neurons in the locus coeruleus, which have got high firing rates during wake, which is reduced in non-REM sleep and silent in REM sleep. And it would appear like these neurons are particularly important in situations where you are challenged or where you're under stress. They seem to fire quite rapidly. You have got a rapid firing rate in those states. So wakefulness predominantly seems to depend on the activity of this ascending reticular activating system, just as was described years ago by Jove and his colleagues when they were doing the transection of the cat brain. So we do have the locus coeruleus, the LDT-PPD, which are cholinergic, the dorsal raphe nuclei, which are serotonergic, the TMN and the dopaminergic areas feeding to the thalamus, basal forebrain, and to the cortex, leading to wakefulness. Then moving to the basal forebrain, it has got two main neurotransmitters. You've got the cholinergic neurons from the basal forebrain, which project to the cortical pyramidal cells and cause wakefulness. And we also GABAergic neurons, which has got a different action from the GABAergic neurons in the VLPO. These neurons disinhibit the cortical neurons and might also contribute to wakefulness. And we know that damage to that area in the basal forebrain is associated with an increased sleep propensity. So, summary of the brain areas important for sleep, starting with the hypothalamic regions. I hope you remembered this. We got the lateral hypothalamus, which got hypocretin secreting neurons, which are very much excitatory. The VLPO, which have got inhibitory GABA and galanin neurons. The TMN, which has got histaminergic excitatory neurons. Then the brain stem regions, the dorsal raphe nucleus, serotonin, the noradrenergic locus coeruleus, the cholinergic LDT, PPT, and then the dopaminergic areas, and the basal forebrain, acetylcholine, and GABA. So a variety of neurochemical systems promote arousal via projections to the forebrain, the thalamus, and the cortex. So if one were to put an EEG during wake, we'll see this fast, low voltage EEG of wakefulness. And in non-REM sleep, we'll see the slow, high voltage EEG. In REM sleep, we've got this EEG, which is almost similar to the wake EEG. And in the LDT, PPT, you've got the wake on and REM on neurons, which are active in the wake and in REM sleep, but not active in non-REM sleep. And we also have in the same area, the REM on neurons, which are not active in wake, which are not active in non-REM sleep, but active in REM sleep. Then in the TMN, that's the histaminergic, as you will recall, we got activity, high firing rates during wake, which is reduced in non-REM sleep and absent in REM sleep. The dorsal raphe nucleus has got serotonergic neurons, which are active during wake, less active during non-REM sleep, and low activity in REM sleep. And the adrenergic locus coeruleus neurons active in wake, less active in non-REM sleep, and absent in REM sleep. And the VLPO, you remember, that's the one which promotes sleep, not active at all during wake, but active in non-REM and REM sleep. Hypocretin cells, neurons from the lateral hypothalamus, maximally active during wake, but with no activity in sleep. And the dopamine firing rates are a bit debated. There are only some groups of cells which seem to fire rapidly during wake, and others seem to have a dopaminergic tone which does not seem to vary that much, but a very important area for treatment of sleepiness. So the control of REM sleep is now just being understood. We do have these inhibitory neurons in the VLPO and the median preoptic area, which contain GABA and galanin, which fire most frequently during non-REM sleep and to some extent during REM sleep, but virtually silent during wakefulness. And these neurons also have an inhibitory on the wake promoting areas, and this helps result in REM sleep. So we increase neuronal activity in the VLPO and the MNPO of the anterior hypothalamus, inhibitory projections to the other nuclei, and leading to REM sleep, non-REM sleep. Control of REM sleep is a little bit more complicated. It's got more complex neurocircuitry. We were talking of the REM-on cells and the REM-off cells. So the REM-on neurons are active or increase firing during REM and cease significantly or decrease significantly during non-REM sleep and the waking state. And the REM-off neurons do the opposite. But you also have input from other cholinergic neurons which seem to modulate the REM-on neurons. And you've got input from the locus coeruleus noradrenergic neurons, which seems to modulate the REM-off neurons. And more recently, it has also been noted that the glutamatergic neurons seem to initiate the whole REM sleep process. And in REM sleep, all muscles are paralyzed so that you don't act out your dreams. It's only the diaphragm which maintains breathing and respiration during REM sleep and the rapid eye movement, as you know. So another important component of the REM sleep is the muscle atonia, the loss of tone in your muscles. And the LDT and the PPT neurons also activate the atonia promoting neurons in the ventromedial medulla. So they release GABA and glycine onto the spinal and brainstem motor neurons during REM sleep. And this causes hyperpolarization and inhibition, leading to the REM atonia. Another factor which contributes to the REM atonia is the withdrawal of the noradrenergic tone on the muscles. And that results in the REM atonia, which is an important feature of dream sleep. And if this system were to go wrong one way or the other, you might have this terrible situation where you might act out your dream, the dream enactment behavior you see in patients with REM behavior disorder. So the REM circuitry is quite complex. I didn't want to include the diagrams with the complex projections and all the other neurotransmitters which have now been suggested to contribute to REM sleep because it becomes quite confusing. So another feature of the REM sleep is the cortical desynchrony, which is almost similar to wakefulness. So you do have the REM active cholinergic neurons activating the thalamus, leading to the cortical desynchrony, which is manifested on the EEG. So you do have these mutually inhibitory circuits During wakefulness, there is high monoaminergic and cholinergic tone, which silences the VLPO, thus disinhibiting the arousal regions and helping ensure the production of complete wakefulness. And during sleep, the VLPO neurons become active and inhibit the arousal regions, thus disinhibiting their own firing. So mutual antagonism between sleep promoting and wake promoting systems is what seems to help in the regulation of sleep and wake, the flip-flop switch. When I was preparing these slides, my little boy came and asked me, what are you saying about this control of sleep? And I tried to explain it to him in a way he can understand. And I said, we've got the forces of darkness and the forces of light. During the day, the forces of light are quite energetic and they are firing. And by evening time, perhaps they are very tired. And the forces of darkness might find the opportunity to outgun them, and they'll continue firing throughout the night. And by morning time, it might be time for them to, well, by morning time, they might be tired, and then the day forces might take over, sort of suggesting that sleep at night is not just a withdrawal of the activity of wakefulness. It's an active process with neuronal activity from the VLPO being useful in initiating and maintaining sleep. There are some clinical correlates on what can go wrong with all these systems. Like with narcolepsy, you've got the instability of the boundary between wake and sleep. And in particular, the control of REM sleep is impaired. So you might have intrusion of REM sleep into wakefulness, manifesting as cataplexy, as sleep paralysis, or the intrusion of REM sleep into wakefulness, manifesting as cataplexy. Then you got REM sleep disorder, where you've got that loss of REM atonia, that paralysis, which should characterize REM sleep, not working, and then you start to act out your dreams. A very important clinical diagnosis, because we now know that it is a harbinger of development of neurodegenerative conditions such as Parkinson's disease. So I'll briefly mention somnogens, which are diffusible or circulating factors that act upon many brain regions to promote sleep. The important one is adenosine, but we also have others like prostaglandin D2, interleukins, TNF, and nitrous oxide, which seems to be important at a cortical level. So caffeine, as we know, is a drug which has been in use for centuries. First used in Ethiopia, went to India, and then came to Europe and the Americas, and is now in common use. And it works by blocking adenosine receptors and promoting wakefulness. We know that there's a buildup of adenosine the longer you have been awake for. So caffeine, a very important drug at promoting wakefulness. And we also know that during infections, there is productions of cytokines which might cause sleepiness. We also know that in African trypanosomiasis, there's inflammation associated with an increase in CSF prostaglandin 2. So these are somnogens which are important for inducing sleepiness. And there is this theory, the two-model theory, which has been proposed, and which seems to hold true in many respects. The longer one is awake, the more likely one is to sleep, perhaps mirroring the accumulation of the adenosine in the basal forebrain, but there could be many other somnogens which are responsible for this homeostatic pressure, the process S. And I'm sure you'll be familiar with the hypothalamic suprachiasmatic nuclei, which contain the master circadian pacemaker, which is important in sleep timing, Of course, I won't discuss the circadian rhythm disorders, but suffice to say, melatonin is produced from the pineal gland and it acts on M1 and M2 melatonin receptors, and it has a role in promotion of sleep. It has a role in the regulation of the circadian rhythm and might have other properties. So melatonin is commonly used both at physiological, especially if you want to manage the circadian rhythms, you want to use low doses, and at pharmacological doses. Rameltion is a melatonin receptor agonist used to treat insomnia, and the antidepressant agomelatine is an agonist of the melatonergic MT1, MT2 receptors, as well as a 5-HT receptor antagonist. So a drug which I've not really, I think I've used it once or twice, very hard to come by, and the patients I've used it on, I think they had already been commenced on the treatment in the USA. So to attain sleep, you need to have the neural circuitry functioning properly. You also need to work in concert with the circadian rhythm, the homeostatic sleep drive, and the psychophysiological profile must be okay, and that should allow you to sleep. But in insomnia, since this is an insomnia afternoon, what could go wrong? I don't know. Maybe it's a faulty flip-flop switch with blurring of the boundaries between wake and sleep. Perhaps there's a hyperactivity arousal of the arousal system and the wake promoting systems. And this hyperarousal theory is gaining traction. Perhaps there's reduced GABAergic activity or increased orexinergic activity. Various possibilities of what could cause insomnia and might also be important on phenotyping insomnia. As we have mentioned throughout the presentation, the talk is that there is a neurobiological basis for the medications we tend to use. We are now moving into the area where the DORAs are becoming quite useful. The hypocretin antagonism and suppression of the wake promoting might be very useful. The melatonin, rameltion, again, I don't have much experience with that, but I won't go into all those drugs. Dr. Selsik has already talked about most of them. So in summary, the central nervous system undergoes several dynamic changes during sleep, which are coordinated by the pons, the basal forebrain areas, and other subcortical structures. The locus coeruleus, which is noradrenergic, and the dorsal raphe nucleus, which is serotonergic, are most active during wake and become progressively less active in the transition from non-REM sleep to REM sleep. On the other hand, the cholinergic neurons in the dorsolateral tegmental and pedunculopontine nuclei area are active both during wake and REM sleep. The histaminergic areas, the TMN, tuberomammillary nucleus, are active during wake and during episodes of cataplexy. Hypocretin from the lateral hypothalamus provide an excitatory input to all the wake promoting regions. And the neurons in the VLPO, as we mentioned, are important because they are active during sleep and are inhibitory to the wake promoting regions. The pons is critical for production of REM sleep. This is a fact which was established some decades ago by Jove and colleagues and still holds true today. And the timing of sleep depends on the interaction between the circadian pacemaker, process C, and the homeostatic mechanism, process S. But of course, the vicissitudes of life do have an influence on whether we are going to sleep or not. Thank you for your attention.
Brilliant. Thanks very much, Rex. That's brilliant. I'm not sure if I'm back on. I can't see myself there. Great. There's quite a few questions come through in the chat. Thanks for that. Maybe I want to go and get my neuroanatomy textbook out and try and mug up on some things there. I'm quite enjoying the thought of the forces of the light and darkness raging within, specifically related to sleep, obviously, not in a moral sense. So I wanted to go through some of the questions that are in the chat. One of them was, do gut peptides like ghrelin and leptin act in the same way on hypocretin and stimulate wakefulness, or is it the other way around? That was a kind of one question. Shall I go one at a time on these?
I think so, because I do not know most of the answers, but yes, they seem to stimulate wakefulness, and it seems to be sensible to do so, because when you don't have food, you should be more vigilant so that you can go and get out food. And I think that's probably why they sort of feed onto the into that system. But again, this I cannot profess to know the answers to these questions.
Brilliant. There's another question which was, is poor REM sleep related to, is the sort of effect on REM sleep related with SSRI use, is that a dose related? So the example is, would reducing the dose of an SSRI tend to help improve REM sleep if a patient has insomnia?
I think there's some dose relation, but it seems also to be a class related, and most of the SSRIs will reduce REM sleep, and the dose certainly seems to impact, especially from our casual observations on polysomnography. Patients on high doses of SSRIs or on multiple or two drugs, they seem to have very reduced, sometimes only one cycle of REM sleep per night. But again, these are very tricky questions.
There was one that was quite detailed, so I'm going to go through it. It was quite specific. So, as a patient who had Bickerstaff encephalitis as a young man who had a prolonged period of sleepiness, then he presented again later in life following a limbic encephalitis. He was seen as an outpatient, complained of daytime sleepiness, which was impairing his and his wife's quality of life. He had a reactive mood. He was responding well to social contact, but otherwise he spent a lot of the day asleep. And the question was, would there have been any suggestion for pharmacological intervention with him? So they tried some behavioral stuff.
Absolutely. Absolutely. These are patients we would like to see, and we would like to sort of do polysomnographic studies, even multiple sleep latency tests, to confirm to have an objective assessment of their sleepiness. Furthermore, we might want to do HLA typing, but perhaps more importantly, we might want to do a lumbar puncture to measure the amount of CSF hypocretin. And these patients should probably be treated like narcoleptic patients. So it would appear like if you go back to the experiments of to the observations of Baron van Economo, if encephalitis was affecting the wake-promoting regions, like the lateral hypothalamus region, that will result in excessive daytime sleepiness. What my colleague, Professor Williams, to say, an experiment of nature really showing that that area is important for wake generation. And so this patient should be referred to a sleep clinic and get proper assessment and maybe therapeutic trials with wake promoting agents.
Thanks, that really answers that one. There was a question, and this is a sort of more broader, it's a bit of $1 million question in some ways, the factors, and I think you touched on it at the end of your talk, but I'll get the question out. So what are the factors that might determine the duration of a particular sleep cycle? How is the brain switching between sleep promoting circuitry into the inhibited linked to wake, the inhibition leading to wakefulness?
I think it's sort of a tricky question. I know it's a balance of this mutual antagonism between the REM on and the REM off cells, the non-REM cells. So it will determine. So the sleep cycling is actually a result of the propagation of that antagonism or auto-inhibitory systems of non-REM sleep, of REM sleep, and also the timing of wake is now a little bit more complex because you are going to factor in the circadian rhythm and the homeostatic pressure, in addition to that mutual antagonism between the wake promoting centers and the sleep promoting centers.
Sorry, yes, great. I'm just going through because there's another one come through. So there was a question about is there an association? Are there any associations between the neuroanatomy of sleep disorders and those of appetites, sort of appetite-related eating disorders, such as seen in Klein-Levine syndrome? And the question was, might some diencephalic regions be especially vulnerable to neurotropic viral infections?
Wow, that's a complex question, but yes, I do agree with what he's saying. The Klein-Levin syndrome is associated with other features such as hyperphagia, hypersexuality. So it appears there are some neuronal projections to the centers which affect eating, which affect the sexual drive, but I won't be able to tell you about the details of that neurocircuitry. It's a fairly rare condition, and we see a few patients in our center here which are being sort of followed up by my colleague Professor Guy Leshner, and we don't understand it very well, and even treatment is still very much not standardized. So I don't have a full answer for that, I'm sorry to say.
No, thanks.
Maybe my colleague, Dr. Yuselsik, might have an input on that if he's still around, or maybe Professor SP.
I think I'm not sure if Professor SP is around. I know Dr. Selsik had to go. I think it's his daughter's birthday. Oh. I wanted to. There's another one there though. Sorry. So how we doing? We've got a few minutes. So one was. Any comments or thoughts on long COVID somnolence? So I don't know if that's come into your clinic at all.
No, it hasn't come into our clinics, but we have seen, in fact, I was doing a paper with one of my students looking at the unholy trinity of obesity, obstructive sleep apnea, and COVID. So we are seeing patients who are very sleepy, because they do have obstructive sleep apnea. And as you know, most of the patients who got COVID badly were the obese patients. So to separate the long COVID from the OSA associated sleepiness is a bit tricky, but by and large, the majority of the patients who are coming into our clinics are being referred by our colleagues from the post-ITU clinic, where they would have assessed them and have looked for that possibility of obstructive sleep apnea. And from the simple cohort I have, about sort of 60–70% of them have severe obstructive sleep apnea, and a good reason for them to be excessively sleepy. I'm not sure whether COVID particularly has a predilection for the wake systems in the brain, as was the case with encephalitis lethargica, but I don't think we're getting that signal at all. It seems like the predominant symptom seems to be fatigue, crushing fatigue, rather than excessive daytime sleepiness. If they're excessively sleepy, we recommend to screen for sleep apnea.
I mean, relatedly, I wondered if you'd seen if you've seen there was a sense that there might be patients with kind of chronic but slightly subclinical OSA who then, due to COVID and was sort of then a longer term inflammatory process, have then tipped into a kind of symptomatic OSA. Is that something that's part of the picture?
I'm not sure. I'm not sure that that would tip them into symptomatic OSA. In fact, what seems to have happened with most of the patients who had severe COVID, they get admitted to hospital, they are unwell for quite some time, and they lose a lot of weight. And another treatment of sleep apnea is weight loss. So that's one of the most important treatments of sleep apnea. And when the ones we see who are coming from the clinics are the ones whose weight loss has not been sufficient to get rid of their sleep apnea.
Okay, that's very interesting. There's a couple more I think we can just about squeeze in. So one was your view on the impact of adverse childhood experiences, traumas on sleep in children and young people, and if there's a role for sort of medications or other options for tackling that.
I didn't quite get it, but you're saying the role of adverse childhood experiences on sleep.
Yeah, adverse childhood experience, yes, and then what sort of possible pharmacological or other methods to address.
Yes, if I don't know how to answer that question properly. I might leave it to my psychological colleagues, but we sometimes use prazosin in post-traumatic stress disorder and the nightmares which may be associated with childhood experiences. But I think that's sort of maybe to do with more of psychological issues rather than the sort of neurobiology of sleep per se.
Yeah. I think I can squeeze in at least one more question. One was around just your thoughts on orexin or hypocretin antagonists in the UK and their sort of why they're not here and if they might be coming through as a new.
Yes. I've been working with, like I said, I've been working with guys from Medscape, and I've looked at the data with them. And I am, maybe I'm biased because I've been working with them. I think they are good drugs. I think they are a useful alternative to the treatment of insomnia. They do not have the side effects which you were discussing with Dr. Yuselsik. And they seem to be effective at improving the night. And they were looking at, I think, the IDSC, the tool to monitor their daytime functionality, and they don't seem to impair daytime functionality. And they seem to be effective at sleep initiation, sleep maintenance, and early morning waking. So I do hope that daridorexant will be approved by NICE. At the moment, we are treating our patients with off-label medications, and that cannot be right.
Okay. Is there a cost barrier then likely, even if it is approved by NICE?
Yes, there will be a cost. These are new medications, so there will be a cost. I cannot. I don't have the cost with me right now, but yes, there is a cost barrier to be considered. Absolutely. But if you look at the impact of insomnia on a long-term basis, it might be worth using these medications.
Great. So kind of watch this space for that one. Is there a timeline on that? NICE, is that what we think in the next year or two that's coming out, or the guidance?
I don't know. I should guess within, I don't know, within months or a year or two. I don't know. I really don't know.
Off topic. Right, last with 1 minute to go. Just given your expertise in obstructive sleep apnea, patients who have insomnia, even when they got optimized CPAP treatment, do you advocate for sort of concurrent hypnotic use of hypnotics concurrently with them?
I have used them, and we can use them. And we know that patients with insomnia tolerate CPAP therapy poorly. You need them to be asleep to be able to tolerate CPAP. So it is important to treat the insomnia. So that's where you might want to choose drugs which are less likely to worsen the sleep apnea. That's where you might find drugs like low-dose doxepin useful. That's where you might find drugs like DORAs useful. They won't worsen your sleep apnea. So I think it is an important point you are raising, and it's very, very difficult to treat comorbid insomnia in patients with sleep apnea.
Brilliant. Thanks for that. There was one last question, which was, how does Boris Johnson sleep at night? But I think the answer is narcissism. But that's brilliant. So thank you very much for that, Dr. Musa. That was a brilliant talk, and really it's something that was really made accessible. So thank you very much for that.
Thank you so very much.
I'm going to hand over to Brent, Dr. Brent Elliott now to introduce the last speaker.
Great. So for our final presentation, it's a real great pleasure to introduce Professor Colin Espy. He is the Professor of Sleep Medicine at the University of Oxford, where he's Director of the Experimental and Clinical Sleep Medicine Research Programme and Clinical Director of the Oxford Online Programme in Sleep Medicine. He's also an Emeritus Professor of Clinical Psychology at the University of Glasgow and is internationally known for his work on insomnia and its treatment using cognitive behavioural therapeutics. He's published over 300 papers and several textbooks, Deputy Editor of the Journal of Sleep Research, and is on the editorial board of Sleep Medicine Reviews. He's a fellow of the British Psychological Society, the Royal Society of Medicine, and the American Academy of Sleep Medicine, and also co-founded Big Health, or the developer of Sleepio, which most of you will probably have heard about and hopefully will hear some more about today. So thank you very much for coming and sharing your experience with us.
Thank you very much, Brent. Thank you for inviting me. Nice to see you all. Thanks for lasting the course today. You've been thinking about sleep all day. I hope you sleep well tonight. I want to tell you a little bit about CBT for insomnia. And as you'll see here, I've quite deliberately called it cognitive and behavioral therapeutics for insomnia, because as you'll find out from my presentation, CBT is not a thing any more than pharmacotherapy is a thing. There's treatment approaches, one of which is pharmaceutical, another of which is more cognitive and behavioral. So thanks for the introduction. Very pleased to be here. If people want to keep in touch, I'm on Twitter at Prof Espy. Put resources up there from time to time. I mean, just to follow up on what we were just thinking about there in the last talk about how sleep is regulated, because I think it's important maybe to understand the ways in which cognitive and behavioral therapies work, because they don't operate at the level of the mind, they operate at the level of the brain, because that's the level at which sleep and wakefulness is regulated. As we know, during the day, we get progressively sleepier, or we would do as we build up debt to the sleep banker. Now at this time of the day, 4 o'clock, we've been awake for quite some hours. But the circadian alerting system times the sleep drive to be delivered at nighttime and keeps us alert during the day. And this is largely a pretty much automated system. If you think about the animal kingdom, animals, your dog doesn't sleep well because it avoids caffeine or uses CBT or takes Ramelteon or Zolpidem. It operates largely at an automated level, presumably under optimal setting conditions. And these conditioned relationships, this adaptive conditioning is very, very important. It's how our kids learn to sleep in their own bed at night, learn to settle there, first of all, learn to fall asleep naturally as the sleep gate opens. So in that adaptive conditioning paradigm, the de-arousal takes place physiologically, at the level of the brain, cortically and autonomically as well. And behavior becomes consolidated, and it's largely a neutral emotional experience. People who are good sleepers aren't good at sleeping. They're not thrilled about it, they never even think about it. They just fall asleep almost involuntarily. They abandon wakefulness really more than anything else. But the person with insomnia seems to have some impairment to these setting conditions and have some maladaptive conditioning. So as they prepare for bed and go to bed, they don't de-arouse in the same way as the person who's a good sleeper. Moreover, when they go into the bed or head hits the pillow, they may actually be wide awake, just in the same way as you may be frightened of a dog or you may not. The same stimulus, same situation creates either a relaxation or an arousal response, a threat response, a comfort response in the brain, to exactly the same situation. So people with insomnia become conditioned to sleep poorly in their bedroom environment. And this inhibits the ability of the homostat, the circadian system, to work correctly. And of course, they also become very emotionally engaged with the process of falling asleep. And the harder they try to fall asleep, the less able they are to sleep. So these maladaptive conditioning relationships, which can be addressed through CBT, are operating at the level of the brain. And I'll give you some more information about this later on. But my key point is pharmaceuticals operate physiologically, CBT operates physiologically. This is where it all started for me. Right, this isn't a sleep lab. It's not a spacecraft. It looks somewhat like it. It's a 1960s a Olympic-sized swimming pool in a new town called East Kilbride. And it was in that new town near Glasgow that I started to do some clinical work. And this building here, which looks as if it's about to fall down or should be pulled down, was in fact at the time a relatively new small health centre, a medical centre. And it was in that setting that a GP said to me one day, I qualified in 1980, by the way, Colin, could you not do anything to help these people that can't sleep? And I said, I don't know, because we've not been taught anything about sleep. I trained as a clinical psychologist, so I've seen people with anxiety and depression, but I was curious, and I did what you did in those days, went to the library and read a few journal articles, took some notes, got things in the interlibrary loan, read up a little bit about the importance of sleep, and realized in a fairly short period of time that the psychological treatment approach, the behavioral treatment approach, could be effective in the management of insomnia. And I published a book in 1991, a textbook on the treatment of insomnia. Bear in mind, in those days, people were still being prescribed barbiturates or had moved on to benzodiazepines. And it turned out the benzodiazepines weren't drugs that patients or doctors loved, because there were many problems with those drugs as well. So I took an interest from the beginning in this behavioral approach, if you like. I spent most of my career working in academia, clinical academic work. For many years was the head of the Department of Psychological Medicine at the University of Glasgow, professor of clinical psychology there. And in the last 10 years or so, I've led the experimental and clinical sleep medicine team at the University of Oxford in the Sleep and Circadian Neuroscience Institute. This is some of the team there, led day to day by Associate Professor Simon Kyle, and it's been great to have Brent as part of our group in recent times doing our sleep medicine master's program. I'll mention that a little bit more later on. These are the kinds of things we're interested in. These are all studies funded by the National Institutes of Health Research. What's the effect of treating insomnia effectively on pre-diabetic states, on emotional cognition, on sleep physiology and cognition? How can you effectively treat, again, using behavioral interventions, sleep and circadian disruption and dementia? How do we better understand the mechanisms of CBT, one of them being sleep restriction therapy, which I'm going to mention a little bit more about in a while? How can we develop clinical and cost effectiveness interventions in primary care? And can use CBT for insomnia as an antidepressant, as a treatment in its own right for depression, as a therapeutic target for depression. So this is some of the work that we're engaged in. Now, what I want to cover with you today are, first of all, these 4 points that I think have been enormous changes in the insomnia landscape over the past 5 to 10 years. Recognition that insomnia is a disorder in its own right, the guidelines that CBT is the best evidence treatment, that treating insomnia effectively may alleviate comorbid mental and physical conditions, consistent with the roles that sleep plays in health and well-being, and that it's increasingly possible to deliver cognitive and behavioral therapeutics digitally, which might make it possible to deliver guideline care. Now, as Brent mentioned, I founded a company about 12 years ago called Big Health that developed Sleepio, and I'm going to mention Sleepio on a couple of occasions. So I want you to recognize, and I want to state plainly, I have a conflict of interest here. But my goal in telling you about this is really to help understand the category and how this approach to delivery, a channel, if you like, to deliver cognitive and behavioral therapy may help to improve healthcare. And I'll mention the literature a little bit more widely than just the Sleepio stuff. Okay, first of all, insomnia is a disorder in its own right. Michael Satea, who's the editor of ICSD-3, and ICSD-3 is now under revision. ICSD-3R will come out, I guess, in a year or so. said that insomnia is insomnia. In other words, we don't need to think of this primary insomnia, secondary insomnia. It's just insomnia, and it should be treated whenever it presents. Chuck Reynolds, the chair of the DSM-5 work group, to achieve optimal treatment outcomes in people with both a psychiatric disorder and insomnia, we need to treat both. There's this idea that, well, it's probably depression that's causing it. We should treat the depression and hopefully the sleep will improve. Doesn't make sense. It's not evidence-based. There's every bit as much evidence that sleep dysregulation makes people vulnerable for depression as there is depression makes people vulnerable to sleep problems. It's truly a bidirectional relationship. So the paradigm shift is towards coding insomnia whenever diagnostic criteria are met, whether or not there's a coexisting disorder in the psychiatric, medical, or indeed sleep disorder domain. And you were talking just latterly with the previous speaker about comorbid insomnia and sleep apnea. And we're doing some work with researchers in Stanford, the National Jewish Hospital in Denver, funded by the NHLBI, National Heart, Lung, Blood Institute, actively treating insomnia alongside sleep apnea. And that study is nearing completion now to see if you can get better clinical outcomes in both conditions. We know that people who've got insomnia, comorbid, the apnea is harder to treat than people who've got comorbid insomnia. So it makes sense to address both. So that's an important paradigm shift, moving through the DSM-5 classification developments through to 2013, the ICSD, International Classification of Sleep Disorders, through to 2014, and the same is happening with ICD-11 whenever that comes out. But I was involved in writing the insomnia section for that. So insomnia is a disorder in its own right. Secondly, the guidelines are that CBT is the best evidence treatment and that CBT should be first-line clinical care. Now, this is quite a kind of important thing to recognize. We've known for a long time now across this timeline here that CBT has become increasingly recognized as the evidence-based treatment for chronic insomnia, not so much for acute insomnia like insomnia that might be transient, but for insomnia once it's established as a chronic problem for 3 or more nights per week for at least 3 months, that insomnia should be treated ideally with CBT. And these guidelines all reflect that through to the most recent, published in the Journal of Clinical Sleep Medicine, the most recent American Academy of Sleep Medicine guidelines. Just to illustrate, here is the guideline from the American College of Physicians, recommendation 1. All adult patients should receive CBT for insomnia as the initial treatment for chronic insomnia disorder, and that a decision should be made as to whether to add pharmacological therapy in adults with chronic insomnia disorder where CBT has been unsuccessful. So that is the guideline. Likewise, if we look at the BAP guideline, which was revised, republished in 2019, CBT first-line treatment and both face-to-face CBT and digital forms of CBT are efficacious, and we'll come back to that shortly. So what this is really telling us is that clinical provision for insomnia should be primarily an ecosystem of psychobiological care. And I've used that term psychobiological just to remind you that the way that psychological interventions most likely operate is at the level of the sleep drive and the circadian timing system, not at some kind of abstracted level of the mind. The European Insomnia Guideline is interesting because it says exactly the same thing, that CBT should be the first-line treatment in adults of any age, but a pharmacological intervention can be offered if CBT is not effective or not available. And I think this is kind of where we are at mostly in most services around the world at the moment. We've got a bit of a paradox of a situation that we've got a treatment that we know is effective, but it's largely unavailable in practice relative to the amount of prescribing. And so this is not a prescribing problem. This is not an over-prescribing problem. This is an under-provision problem, not being able to provide CBT at scale. And we're going to say a little bit more about that shortly. As you would expect, if you think about what is the purpose of sleep, and Alan Rechtschaffen, who developed with Tony Kales the classification systems that we use for staging sleep, human sleep using polysomnography, it was famed for saying that if sleep has no function, it's evolution's biggest ever mistake. One of the main functions of sleep is for brain health, for cognitive health, and for emotion regulation. So we'd expect that if people get a sleep difficulty and we address it successfully, that there should be improvements not just in sleep itself. In a sense, what does it really matter if your sleep improves if nothing else changes? Because the functions of sleep, the purposes of sleep are to deliver wakefulness and good quality function during the daytime. And there is now a lot of evidence that when you treat insomnia effectively, you get medium to large effect size, not just on the target symptom, but on the associated comorbidities, whether those are, in terms of the mental health domain. There's most evidence, for example, about an antidepressant response. But we can treat insomnia effectively, even in comorbid populations. And of course, that is a norm. As you know, with age, comorbidity increases. All types of comorbidities, chronic diseases, mental health problems, functional impairment, musculoskeletal difficulties, disabilities, and so on. Everything accumulates with age. And the average age of the insomnia population is around 50. So there's a lot of comorbidity in this population. And they can still be effectively treated. And the last enormous change, I think, here is that delivering CBT digitally makes a guideline treatment possible at population scale. And I think this is why that might be so. If you think about the molecule is, if you like, the reproducible, effective treatment scalable, effective component in a pharmaceutical, and we reproduce that faithfully, and we deliver it faithfully in such a way that it can be provided at huge scale on any given day. Look at what we've done with vaccines, for example, in the past year or two, a huge scale, once that molecule is synthesized. Now, the difficulty with a cognitive behavioral approach has been that traditionally a CBT has been delivered in person, face to face, and people aren't quite scalable, if you think of it that way, to deliver 14 million prescriptions written annually in the UK, for benzodiazepines or equivalents, either for insomnia or anxiety. 14 million prescriptions. How would you provide 14 million offerings of CBT? You're probably talking about able to do a fragment of that. But of course, software as a medical device, there's the potential to use the algorithm as a scalable equivalent of the molecule, and to be able to use a digitized version of CBT. And I'm talking about something that's fully automated, engaging and fully automated. So CBT is now considered more, in that sense, more like a health technology that can be encapsulated within a program and delivered faithfully to the individual. And there's two, if you look internationally, there's really only two products that have got substantial evidence base. One is called Shut-Eye, which is licensed by Pear Therapeutics under the name of Somrist, and is now available in the States, for example. So Shut-Eye, Somrist has 8 published RCTs, perhaps more now, on about 3,000 participants. And there's Sleepio, which is the product I've been involved with, which has got 12 published RCTs and about 8,000 participants. So there's a large evidence base on these interventions. Now, these are, can be provided at huge scale. They could be given to anyone today, immediately. They could start using them immediately. The Shut-Eye program, for example, had a very impressive study. I'm just using one example from each of these interventions, published in Lancet Psychiatry a number of years ago, showing that it improved not only insomnia, but also led to the prevention of depressive episodes. The Sleepio program, this is one of our trials, published in JAMA Psychiatry, that showed that you get improvements on health-related quality of life and functional outcomes, not just in terms of sleep, but also in relation to these functional outcomes. And this study used a causal mediation analysis, which demonstrated that around 80% of the variance in outcome in health was associated with improvement in sleep. So we have quite a number of changes in the landscape that have really been consolidated in the past years. That insomnia is a disorder. It should be treated when it's recognized. It should ideally be treated with CBT as a first-line care. And if we treat the insomnia effectively, it should also begin to alleviate a comorbid mental and physical health conditions. After all, insomnia is a disorder of a sleep complaint disruption at night, which has now become chronic and frequent, 3 or more nights per week, with reported daytime consequences. In the same way as someone may have depressed mood, may have negative thoughts, may feel a bit flat, but normally in depression, one would expect to see that has some impact on their ability to function. Same with anxiety. They're not just worried, that they're actually not able to function properly. So it's the same kind of situation. And that delivering CBT digitally has a potential, at least, to make guideline care, which is that, insomnia should be treated with CBT, potential to make that scalable. And that's an important development when one thinks about it. If we regard, as many of you are psychiatrists and people working in the mental health space, we'd all be advocates, wouldn't we? That depression or schizophrenia or bipolar illness or insomnia or other disorders that are in the psychiatric nosology are just as important as are those in the medical domain, like heart disease or cancer or diabetes. But would it not be a scandal if we were saying, well, we have effective treatments for cancer, they're just not available? Or we have effective treatments for hypertension or for whatever, but they're just not available. It's not something one should shrug one's shoulder at. How do we make the treatments available? And so that's a huge challenge, I think, about CBT, which has been the evidence-based first-line treatment for some time, but it's generally not available. And this is why this breakthrough is important. So now let's begin to think a little bit towards the future. So I think the first thing I'd want to illustrate to you is something I mentioned earlier on, that CBT isn't a treatment. It's really a system of therapeutics. If someone was to say to you, oh, I got CBT for my insomnia, you would almost certainly say, great, okay, so what did you actually get? What did you actually do? It's a bit like saying, I got pharmacotherapy for my insomnia. Okay, well, what drug did you actually get? What medication was prescribed? Because you're trying to get under the bonnet a little bit of the treatment here, from the kind of family of pharmacotherapy into understanding, which branch of that family was being used. Was it a benzodiazepine receptor agonist, a melatonin receptor agonist, an orexin receptor antagonist? And of course, within that, then you might be thinking, okay, was it zopiclone, zolpidem, isoprolol, zaloplon? And bear in mind that we quite rightly see this as different licensed products, but they're actually kind of similar in many ways. They all operate on benzodiazepine receptors in the same way as do the benzodiazepines, with differential levels of receptor binding. But my point is that they're all different, and that we should regard them as different drugs, in the same way as, you know, with the orexin receptor antagonists. We'd be interested in, well, which particular one were you using? I realize not all these are available. My point really is to help you understand that this is the way we understand the formulary. Now, by analogy, there is a CBT formulary. That cognitive and behavioral therapeutics is the kind of domain equivalent of pharmacotherapy. And there are actually scores of CBTX options, I think, potentially much wider range than pharmacotherapy. If you think of the Z drugs, they're kind of similar to each other in lots of ways. If you think of the elements of CBT, they can be really quite different from each other. There are ones that are in the relaxation territory. There are ones in the behavioral territory, like stimulus control therapeutics and sleep compression and sleep restriction and so on. And there are ones in the more sort of cognitive domain, which are to help people address the arousal associated with the racing mind. And there's many different ones of those. So just to illustrate, you'll see in the schematic here that you might say, so what you say you had CBT, what did you have? I got some help with relaxation. Okay, well, what kind of relaxation approach did you take? This is which Z drug did you have? Progressive relaxation. What happened during the progressive relaxation? And then whether we used an abbreviated form, or we used a Q-controlled form, or we focused on tension release, or focused on diaphragmatic breathing, or various combinations of these things. So yeah, I think the way that we, thinking about the future, should be seeing this is that we can develop a personalized, more precision-based approach to cognitive behavioral therapy, which is a bit like we want to do in medicines management, provide the right treatment for the right person in the right dose at the right time. And that should be driven by case conceptualization rather than just simple diagnostics. And the case conceptualization approach is really understanding how the interplay takes place between predisposing factors, precipitating factors, perpetuating factors, and so on. So there's an analogy here, and analogies always break down, but I think it's maybe helpful, particularly for this audience, to understand that cognitive and behavioral therapeutics is kind of the domain equivalent of pharmacotherapy, and we need to get away from this idea of CBT as a treatment. It's something that over the years has tended to be lumped together rather than split apart. And I think it's important now to get back to the elements of that. So for example, mindfulness therapies, are part of, to my mind, they're cognitive behavioral therapeutics. Do they fit into a relaxation domain, or do they fit into a cognitive domain? It's a kind of moot point. But my point would be that there's different types of mindfulness-based approaches that one could use, and that you could vary those approaches depending on the individual, or you could move from one therapeutic to another, just in the same way as you might move a patient from a BZRA to an ORA, or you might move them from a certain type of BZRA to a different one, or change the dosing of the existing one. So you get many more therapeutic options when one thinks of CBT exploded out like that. Okay, so the future of CBT is to understand it as a system of therapeutics, not as a treatment in its own right, but a broad domain of intervention, the formulary, if you like. I just want to go back to this piece about the brain behavior interface and try to help illustrate that, if your MO as a practicing clinician is to think of yourself as someone who's delivering a treatment that has a physiological effect then do be interested in this cognitive behavioral therapeutics area, because it isn't psychobabble, it's not psychotherapy. It operates at the level of the brain-behavior interface. Let me illustrate that by talking about two therapies very briefly. Consider sleep restriction therapy, right? You may have heard of this as an intervention for insomnia. It's part of the behavioral element of CBT. What you're doing right now in your daytime is, in a sense, a behavioral approach. You're exposing yourself to daylight. You're up and about, and you're if you're feeling a bit tired, you'll move yourself around. We might encourage people clinically to try and make use of the circadian alerting system and get out into the daylight, and because of that, effect on the biological clock and the timing, circadian timing system. With light as a major zeitgeber to daytime and to nighttime. So you'd be using these behavioral instructions to influence the clock by exposure to light, or by using autonomic clues or cues about when we eat or when we act and what we do. Now, what sleep restriction therapy, and we've been studying this quite a bit in the lab and in the community in Oxford in some of our studies, we were trying to isolate the role of time in bed restriction in the treatment of insomnia. Because what you actually do in sleep restriction therapy is you reduce the amount of time that people are spending in bed to be closely matched to the amount of time they say they're sleeping. So if somebody is sleeping 6 hours, but is spending 8 hours in bed, you encourage them to reduce their time in bed by 2 hours. And what that effectively does is it means that they're staying up later and they're getting up at a set time in the morning, usually earlier than that at the moment. And what we found in our studies is it primes the sleep homeostat. It primes the homeostatic drive to have more sleep during that interval. If you like, it trains it into that period and squeezes out the wakefulness that would otherwise take place. If you think of it another way, people with insomnia get so concerned about being unable to sleep that they tend to spend longer in bed than they're possibly able to sleep through. And the less they're able to sleep, the more worried they can become about it, the greater the likelihood of, I need to get to bed early tonight, I need to catch up on my sleep, try and sleep in a bit later. So what they in effect do is reduce the efficiency of their sleep. That is the proportion of time in bed that they're actually sleeping. So if they're sleeping 6 hours but in bed 8, that's a 75% sleep efficiency. You can make that sleep efficiency close to 100%. Well, nobody's 100%, but you can push it to 85, 90% plus by reducing the denominator of the equation rather than trying to increase the numerator. What they want to do is to sleep 8 hours, so that's 8 hours right, sleeping right through, but you can restrict the time in bed to closer to 6. And they find very quickly that they sleep through a shorter window. And we've been demonstrating the effects that this has on circadian timing, on vigilance and the expression of melatonin, and on the homeostatic drive for sleep as measured using PSG and power spectral analysis. These are behavioral interventions that have if you like, a biological effect. So it's not psychobabble. Then if one considers another element of behavioral intervention, which is called stimulus control therapy, if I ask you the question, why do you brush your teeth? Most people would answer that question by saying, well, one brushes one's teeth to maintain good dental hygiene, to prevent dental disease, and so you don't have toothache, so you don't have a decay in your teeth. That's nonsense. That's rubbish. That's not why you brush your teeth. It's why intellectually you should brush your teeth, but you brush your teeth because you just got into your pajamas. You brush your teeth as part of a routine of behavior that's now kind of hardwired into your brain behavior relationship. You do it in the same as I'm talking to you just now. You're not really thinking about it, just part of a pattern. You've chosen to sit down to attend to this, so you hear it. you've set the conditions for it. Here's a really interesting study that was published very recently in Current Biology. And what the researchers here did was they disrupted the nesting behavior of mice. The grooming and nesting kind of behavior, the rituals, the routines these mice go through just before they fall asleep. Just in the same way as we have our rituals. The mice have the rituals. But what they found was when they just disrupted those rituals, disrupted that nesting behavior, the mice struggled to get to sleep. They almost had like an experimental form of insomnia. And moreover, when they did sleep, their sleep quality was poorer when they were actually asleep. And this seems very similar to me to what actually happens under stimulus control environment. That in the stimulus environment of a bed, a good sleeper kind of automatically kind of falls asleep relatively naturally because the bed sleep connection is there. It's overlearned. It just happens in sequence. You get into your jammies, you brush your teeth, you put the light off in the ensuite, you go into your bed, you lie down on your preferred side, you put the light out and you fall asleep. No credit to you. It all just happens as part of a behavioral sequence. But if you get insomnia, that behavioral sequence is now associated with bed wakefulness. In the same way as for these mice, it become disruption to sleep initiation and poor quality sleep, just through a behavioral intervention, affecting directly a conditioning brain behavior relationship. So I think the future of CBT is recognizing that there's a bunch of different therapeutics, that it's not psychobabble, but also that it can be delivered digitally, as already mentioned, as a treatment, and that might be able to deliver guideline care. Brent mentioned earlier on about Sleepio. There was a nice guideline on Sleepio that was published on the 20th of May, recommending it as a cost-saving option for treating insomnia in primary care for people who would otherwise be offered sleep hygiene or sleeping pills. So here we're at the beginning, potentially, of that. Unfortunately, it's not actually funded at the moment, although there's a guideline for it. It's available in Scotland, but not yet throughout England. But my point really is, if you've got a scalable way of doing this, you may be able to deliver guideline care. And I think the way this is going to go, and here I'm talking at the general category level, that digital health is going to become bifurcated into digital therapeutics and well-being apps. At the moment, we understand that difference pretty clearly when it comes to pills. I could show you this white pill and this white pill. And I would say these are both pills, these are both tablets. But one is a treatment and one is a homeopathic remedy. One is something you can buy as a discretionary spend in the chemist or in Tesco's or wherever. The other is a recognized treatment. One's got an evidence base and one kind of doesn't really. Now, we already understand those differences. I think that's simply what's going to happen with the digital space. It'll be bifurcated into digital therapeutics, which is the term that's now increasingly used in this new whole industry, that will become like the equivalent of the pharmaceutical industry, but using software as a medical device. That where an intervention is designed as a medicine, it will deliver a clinical endpoints and will need to have an evidence base. A trials pipeline, nothing any different from anything else, needs to be regulated in just the same way to the same gold standard evidence as any other therapeutic. Randomized controlled trials followed by large volumes of real world evidence and demonstration of being value for money. In the previous talk, mention was made of the orexin receptor antagonists and whether and when NICE would recommend them. That will depend upon clinical evidence and evidence of cost efficiency. Just the same will apply to any treatment. There should be no special pleading for digital therapeutics, I have to say. And it frustrates me when I hear that, this is kind of difficult. Well, the truth of the matter is that the digital therapeutics industry is reckoned to be heading towards a valuation of somewhere around 35 billion. This is a massively capitalized area of industry. So there's no reason at all that we should be thinking, oh, it's only an app. We can have apps that are simply in app stores, just like you would have things in shelves that you could buy if you wanted. But things that are therapeutics should be in a digital formulary and recognized and recommended. They should not be made available at all until there is the gold standard evidence already published. Just in the same way as you wouldn't think, I think this drug's fine, let's just wing it, let's give it to people. That should not happen if something is going to be a digital therapeutic. And it's that digital therapeutic that I think can help deliver the guideline care that we recognize. It's not apps, it's treatments. And it's not enough just to be evidence informed. To say, oh, we built something, we put CBT in it and CBT works, so this works. You wouldn't be able to do that with a drug and say, well, SSRIs work. We've synthesized a new SSRI. SSRI works, so this drug works. That is not logical and not safe. One has to be able to demonstrate per treatment. Each new drug, even though it's only slightly different from a previous drug, like another Z drug, or it's ezopiclone versus zopiclone. You have to demonstrate again in clinical trials that this particular thing works. That's going to be really important for us to be able to trust this whole area. So I think if we're able to do that, the future is that digital therapeutics, this kind of CBT in a software as a medical device form, in-person care and pharmacotherapy can coexist in a clinical ecosystem to provide choice of evidence-based interventions that patients and ourselves as clinicians can trust. At the moment, we have largely practitioners like clinical psychologists or therapists who deliver in-person care, and we have physicians of different kinds, primary care physicians, specialist psychiatrists, who mostly provide pharmacotherapy. So we get this or this, and sometimes these things connect, but not very much. And of course, this can't really be scaled up, whereas pharmacotherapy can. What digital therapeutics does is provide the option of helping to scale up the cognitive behavioral therapy approach. And it can be recommended, of course, by physicians or recommended by psychologists. It can be used in prescription targeting, for example, to say, well, I can give you this for a short while, but you can then use your digital therapeutic and we'll make that available to you. But this is all, if you like, professionally administered. I think it also makes a lot of sense to create an ecosystem where there's direct access via health providers like the NHS, making evidence-based digital therapeutics more directly available through community access, rather than you're always having to go to see a clinician first of all. So I think there is, without going into this in much detail, an exciting future whereby I think it might be possible within about 5 years, to talk about the previous 5 to 10 years, I think it might become possible to deliver clinical guideline care for insomnia with this kind of diverse ecosystem enabled by digital therapeutics within the next 5 years or so. So just round things off, I just want to mention a few resources which I've been working on, so I just want to share them with you. There is a piece that Dimitri and Simon and I wrote in the most recent edition of the European Sleep Medicine textbook, which is a kind of summary of the CBTI approach. And the textbook is very accessible, both online and to have on your shelf in your department. This is a self-help book that the second edition of which came out last year, which you can provide or recommend to patients. I'm actually working on a textbook. I finished it last week. This will go into Cambridge University Press within the next 2 or 3 months to be proofed and so on. And this is really my best efforts to pass on my 40 years of knowledge, 40 plus years of knowledge, in the how aspect of CBT, because I haven't been able today, in the context of a brief lecture, to be able to talk very much about, well, here's how you do it. This is designed to help you with that. There's also this protocols book that Chiara Baglioni and Dieter Riem and myself have been working on with Wiley, that will come out, I think, at the beginning of next month in August, with clinical protocols for health professionals. So that's just a repeat of the previous one. There's also this I would recommend to you. If you're looking for an alternative to sleep hygiene, there's the 5 principles of good sleep health, which I developed for the Every Mind Matters campaign of the Department of Health and Social Care during COVID, and you can access this and download it at no cost. You can use the appendix in it with patients, and it talks about the importance of valuing, prioritizing, personalizing, and trusting and protecting your health. It's a kind of modern version of a leaflet, if you like. There's the European Academy of CBT, which looks at proposals for CBT workshops and training programs across Europe, and has got criteria for those published in this paper in Journal of Sleep Research that you might want to take a look at. And finally, if people are interested in a deeper dive on sleep medicine more broadly, we do have this program in Oxford, a master's program that Brent has completed. There's also a postgraduate diploma program, but they're 2 years part-time, so they're a lot of work. But we also do workshops from those more individual module level things. We've now had 360 students, probably more than that, going through this program from 35 countries over the past few years. And it's been wonderful to work in this together, to try and really push training, because although I'm mentioning the importance of therapeutics, we need people. We need people who are skilled in this area, and I'm pleased to be able to contribute to that. Okay, so I've tried to leave a little bit of time, Brent, for questions and for some discussion. I'm interested in people's own thoughts, experiences, and certainly happy to answer questions.
That's fantastic. Thank you very much. And I was going to mention the course in my closing comments. I'm just finishing off with the masters, but I think it's absolutely fantastic. Purely online offer that's would be really, really helpful to people working clinically with those with mental health problems. And hopefully this is just a taster really of the many areas of sleep medicine that we hope to introduce you to over the course of the next 5 years. So we'll be doing one of these sleep courses each year within the Barts program, tackling a variety of different elements of sleep-related movement and neurological disorders, etc. But for those of you who are interested in going deeper, there are, as Professor Espy just said, there are individual modules, a PG DIP, and the full masters. So, yeah, fascinating talk and really interesting. I thought the first thing that struck me was that experiment with mice about interrupting routine. Is something any parent of young children would be familiar with when trying to get out of the bedroom early and trying to short circuit the normal routine, and they just keep coming down.
Yeah, that's right. It's so right, isn't it? We're very, very rational as human beings, and we think we figure everything out in a very rational plan. But the truth of the matter is we learn a lot of stuff by trial and error. We've got some guiding principles. We listen to what people suggest. We model their behavior. But as parents of young children, we're just trying stuff out, right? And eventually, our ability to synchronize things successfully doesn't need to be perfect. But it tucks in, it fits in with their developmental capability of being more independent. The parent is able to put their child down awake, and so when they're sleepy, so they can settle spontaneously in the bedroom environment, develops a strong connection between successful sleep and feeling comfortable and not tense or not upset in bed, because they're used to lying awake in bed. So when they wake up, they don't get immediately distressed. These are examples. The reason I'm pulling it out, Brian, these are examples of what we call stimulus control. These are basic psychological principles, but they operate at the level of conditioning, the level of habit, they successfully help us initiate and maintain sleep. you know, they're not just psychological phenomena in some kind of separate bubble.
So just pulling up some questions from the chat and the Q&A. So one is just around the practicalities. Sitting in clinic, I see this patient with insomnia. I'm going to try not to use a Z drug in the first instance. How might I go about it, making a referral for cognitive behavior or gaining access to Sleepio? Because I know it's available in some places on the NHS.
Yeah. So you know, I think what we need to do with these kinds of therapeutics is figure this out in the same ways we've figured this out with recommending other forms of treatment. You know, we talk about the implementation with people. You know, these pills will have these effects. This is what you might expect. This is when you should take them. This is what you should do. So I think we need to have that same conversation around any treatment. The difference potentially, though, is that when you refer someone for CBT, you probably don't really hear anymore, right? They go off. They go on a waiting list, and you get a letter back at some point. But there's no kind of real connection. And likewise, when the psychologist is working in CBT with the individual, the conversation at the consulting room door is something like, well, you know all the things to try this week. I'm going to really try those, doctor. You know, I'm try to get up during the night if I can't sleep, and well, all the very best, right? It's a kind of commissioning process, and there's no data points until the person comes back a week or fortnight later, and you ask them how did they get on, and of course they give you a very, you know, depending on what just happened the night before, or depending how easy it is for them to tell you they didn't do it, or that it didn't work. And of course, there's a response bias, you know, inevitably to kind of say, yeah, thanks, it was helpful. There's a potential to get data points back, you know, from a system that is, you know, that all it can do is gather data really in a way. So I think that's the future for this, you know, that there should be a feedback whereby the clinical service, the individual, can support the individual, can see when they have implemented something, can see their pattern of adherence or non-adherence, can reinforce that, can course correct, can see people who need more help and attention, and to spend a bit less time with people who are managing on their own. And to see them, what most of us would regard as you know, the value in our qualifications, that we spend more time with people who really need our help and really need our time. You know, so I think that interoperability in Sleepio and in any program like this is the kind of thing that needs to be developed to make it really truly integrate into healthcare. So much of healthcare, there isn't really that feedback loop at all. Even in primary care, you know nothing unless the person comes back to say it didn't work. You pretty much say, if I hear nothing, they must be fine, right? You know, so I think there are advantages in terms of implementation with a digital approach, because it's there to support the individual in the moment as they try to do things.
Thank you. So a couple of questions coming to my personal email on through the chat of how do we train in CBT, and do you think that's something that would be a good idea for mental health professionals to do? Yeah.
You know, I'd love to think that you know, training and understanding sleep and how to give basic evidence-based advice about insomnia problems is really, I'd love to think that will become an essential kind of asset that everyone working in the mental health field will have. Yeah, I can't imagine you know, anything more fundamental to emotional health regulation and cognitive health than managing to sleep. You know, so I'd love to think it'll become not just an advanced specialist area that people think this is great, I'd love to specialize in it, but just core foundational mainstream knowledge. In all our basic training and advanced training, there's just stuff on sleep. I think that'll take a bit of time, but I think it is so important. And of course, as part of that, you know, to have an understanding, regardless of your professional background, of the behavioral aspects of intervention. You know, I think a lot of people would welcome that as well, adding that to their skills. I guess one of the reasons we began to develop the kind of program of training in Oxford and began it as an online venture it is really because we had from the beginning this idea of scale. How can we train as many people as possible efficiently alongside their existing work, rather than the time out which people take. Like, for example, for this Barts course, which is great, and it's not to knock that, but it's a both, and to use, to develop centres of excellence, within mainstream services, where it's not just a respiratory sleep service, if you know what I mean. It's a service around sleep. These are all important, I think.
Absolutely. There's a question here about quick wins in a clinic. So is there a middle ground between something that we can do that's non-pharm, between seeing a patient and then referring them on for a more definitive psychotherapeutic behavioral approach?
Yes. Yeah, I mean, I think if we begin to see, at the moment CBT sounds something kind of like amorphous, and well, I don't really know how to do that. So what we end up doing is giving people some tips which they've already read in the Daily Mail, right? And it sounds kind of crass. Have you thought maybe about drinking less coffee, trying to get your sleep into a proper schedule, not worrying about it? Imagine if we said that to someone who's depressed, who's bipolar illness. I think try to get some more stable habits and maybe get up at a regular time each day, and just remember there's people worse off than you. These kind of attempts at therapy, don't just not work. They grate with people, and I think that the quick thing we can try might often feel a bit like that sleep hygiene thing, or an emotional hygiene for depression would sound similar. Whereas if we step back a little bit, the CBT is not out of reach. Maybe we can take one thing from CBT that we think for that individual this might work, one element, one particular thing, and say, look, there's one thing I'd like you to try. I'd like you to try not to lie awake in bed. This is a very, very difficult thing to do. You're awake for 90 minutes at the moment, roughly every night. You're saying, sometime can I get to sleep? Sometime when you're awake during the night, adds up to an hour and a half, 2 hours. Try not to lie awake in bed for more than a quarter of an hour. So you're awake for, at the moment, at least 6 quarters. If you were to get up 6 times a night for a week, have you ever tried that? Because people quickly say, I've tried CBT, it didn't work. I've tried everything. So I'm just using that as an example. You could pick something that is accessible to you, that you think might work for that individual, that it's got more depth to it as an intervention than these superficial sleep hygiene things. Because often we find that people with insomnia have got better sleep hygiene than the general population, because they've already thought about all these things. So I think that toolkit approach is, and it's also one of the reasons that I developed the 5 principles of good sleep health, just to be able to give, here, try this, here's another leaflet, but it's actually a different approach to thinking about it. So that may be something folk could try as well.
I think I've got time for one more question, which is, how should I manage middle of the night waking? And my quick answer would be to do a CBTI training course where we talk about methods of managing that, but I wondered if you had any comments on that.
Yes, well, I think middle of the night waking is a bit like hair loss, right? It gets worse as you get older, right? You're there with a brilliant head of hair, Brent. I've got follicular jealous envy, so fragmentation of sleep, as well as some change in circadian amplitude, towards lighter sleep, and the invasion of wakefulness into the night and sleepiness into the day are developmental norms. So what we need to try and address here is a struggle to get back to sleep, rather than the awakening per se. I think we sometimes say, oh, I shouldn't have woken up. How do I stop waking up? I think if we change the narrative to waking up is okay. In fact, the more often you wake up, the more reassured you might be about how quickly you can get back to sleep. These are all opportunities. But the problem is that at the moment, if you wake at 4 in the morning, you think, it's 4 in the morning, I've only had so many hours sleep. I've only got so long to go. If I don't get sleep of this amount in the next 3 hours, I'm not going to be able to function tomorrow. Whereas another person, down the street from you, same age as you, the same tendency to waking up during the night, woke up at 4 in the morning, thinks, it's only 4 o'clock in the morning, I still get 2 or 3 hours. Hey, right? You've just got a completely different kind of mindset to the same situation. One makes you focus on worrying about being awake, gets you hyper aroused, makes you try to sleep, and you get an insomnia form of hyperventilation, right? The more you try to sleep, the more you hyper arouse. In the same way as the more you try to breathe, the more you hyperventilate, right? So just switching that kind of way of thinking has not just a change in the mindset, but it's a change in the physiological response to the situation. So these are the kinds of things that are part of a cognitive therapy element of CBT, but again, can be distilled down into very helpful specific pieces of advice that you might think that's the appropriate thing to say to this patient. So I've given you 2 examples there, one from the more cognitive domain and one from the quarter of an hour rule of behavioral domain. But come and train, come and do more work with us. We'd love to have you.
It's absolutely marvellous. Thank you very much. And you've managed to retain, even at 5:02, the attention of 132 participants, mental health professionals, all learning something more about insomnia. So thank you again to all of our speakers. You've been wonderful. It's been great having you here. And thanks for helping me to spread the word, really spread some knowledge about sleep disorders. Hopefully among our trainees, this has inspired you to learn a bit more about this fascinating area, and we'll see you again in a year with the next instalment of Introduction to Sleep Disorders.